have with us Dr. Sambit Das, endocrinologist and general physician, Apollo Hospital, to moderate our first session. Over to Sambit, sir.
So thanks a lot. A very good evening, dear friends. And today we have a wonderful symposium known as type 2 diabetes and heart failure. And
sir, can you please unmute, sir?
Yeah, it's audible. Hello.
Yes, sir.
Yeah. Is it audible?
Yes, okay.
Sir. Okay. A very good evening, everyone. So welcome to JPEF 2020. At the outset, I must thank Dr. Jothydev for giving this opportunity. And today, right now, we are going to have a wonderful symposium known as type 2 diabetes and heart failure. And friends, as you all know, that heart failure is an important menace in management of type 2 diabetes, and many admissions in hospitalization due to heart failure is a major problem in patients with type 2 diabetes. So to discuss about heart failure in type 2 diabetes and the role of newer drugs in managing heart failure and how we should target the glycemic control and all, we have two very eminent speakers for today. And I have the privilege to introduce Dr. Silvio Enzosi from US and Professor Sasank Joshi sir from India. So Professor Silvio Enzosi is the clinical chief of section of endocrinology and medical director at the Yale Diabetes Center. And he's a well-known as an author and lecturer in diabetes management. And he served as a co-chair of the AD-ESD position statement in the management of hyperglycemia in type 2 diabetes. And he held very important leadership positions all over the world in the field of diabetes. And he has been a principal investigator in DAPA-HF trial. So Dr. Enzosi will be discussing about type 2 management of heart failure in type 2 diabetes, with obviously how the recent trials have modified our view on how we should manage heart failure in diabetes. So over to Dr. Silvio.
Thank you very much, Dr. Das. It's a great pleasure to be here today. I'm going to share my screen. Hopefully everybody can see the first slide, which is the title of the lecture today, next 20 minutes or so, evolving role of SGLT2 inhibitors in the management of patients with type 2 diabetes and heart failure. And hopefully I can present some insights from recent clinical trials. These are my disclosures. So heart failure is now an under-recognized diabetes complication. We all recognize myocardial infarction, stroke, peripheral arterial disease as major macrovascular complications. But actually in this analysis, the excess risk for heart failure is even greater than these other atherosclerotic types of complications of type 2 diabetes. Once it is established, type 2 diabetes has a very poor prognosis. You can see in this analysis from the United States in a Medicare population, a patient with diabetes, once they develop heart failure, has a mortality over 5 years in excess of 80%. And some have compared this to the prognosis in patients with metastatic cancer. So it would be obvious to most people that if you control diabetes, you could mitigate this risk, but that is actually not the case. From the UKPDS, ACCORD, ADVANCE, and VADT comes a meta-analysis that was published more than 10 years ago that determined that the point estimate for the diagnosis of heart failure in those patients who were treated more intensively or less intensively was absolutely neutral at 1.00. So it seems that glucose control itself cannot reduce heart failure hospitalization rates. These are the various treatments that are in widespread use throughout the world for managing hyperglycemia in patients with type 2 diabetes, from insulin, sulfonylureas, metformin, thiazole, dindiones, DPP-4 inhibitors, GLP-1 receptor agonists, and SGLT2 inhibitors. So now we're going to address whether specific glucose-lowering medications could have a attenuating effect on the diagnosis of heart failure. Very clearly with insulin and sulfonylureas, the answer is no, that these drugs are probably neutral. In other words, they don't have any specific advantage in terms of preventing heart failure hospitalization or heart failure mortality. With metformin, I think the verdict is still out. As you know, there are some data from UKPDS, the HOME study, suggesting a macrovascular benefit from metformin. But when one looks at the diagnosis of heart failure, there are no randomized clinical trials. There was some observational data that was published more than 10 years ago, suggesting that patients who were discharged from hospitals with metformin as their glucose-lowering medication did have reduced mortality. But there's obviously selection biases here, but again, no RCT data to support this contention. And very clearly, the thiazolidinediones, when they are used in patients with type 2 diabetes, increase heart failure events, likely due to increasing sodium reabsorption at the level of the distal nephron, not necessarily a deleterious effect on cardiac function or certainly cardiac structure, but simply a manifestation of salt overload. And then obviously the alphabet soup of type 2 diabetes therapy, DPP-4s, GLP-1s, and SGLT2 inhibitors were now considered more rigorously tested, both for atherosclerotic cardiovascular complications, but also for heart failure after the 2008 FDA guidance that demonstrated to industry that the regulatory bodies were very serious about guaranteeing that drugs used for glucose lowering were at least neutral on cardiovascular events. You recall that this had stemmed from several years of controversy about the potential deleterious effect of glucose-lowering medications on certain cardiovascular outcomes. We already mentioned the TZDs in heart failure, but other medications as well, such as some of the PPAR agonists had emerged. So regulatory bodies across the world now mandated from industry the demonstration of cardiovascular safety. And these are the dozen or so cardiovascular outcome trials that emanated from the 2008 guidance from the DPP-4s, the GLP-1s, and the SGLT2s. We won't spend time on the DPP-4s. Clearly, these are neutral. They do not increase or decrease major adverse cardiovascular events. Two drugs, saxagliptin and alogliptin, had the suggestion of a potential negative effect on heart failure. And the reason for that is not clear, not seen with any of the other gliptins, but a cautionary tale that some of these medications may have potential negative effects on cardiac function. So DPP-4s, I feel, are probably neutral as a group for heart failure, although with the specific mention of saxagliptin and perhaps even alogliptin potentially being deleterious. The next series of studies were obviously the SGLT2 inhibitors. These are the glucosuric agents that induce not only reductions in hemoglobin A1C, but also to a modest extent, body weight and blood pressure. And this was a surprising result from the first SGLT2 inhibitor trial that was released, known as EMPA-REG Outcome, studying the SGLT2 inhibitor empagliflozin. And what was striking in the EMPA-REG Outcome study was this almost unbelievable 38% reduction in cardiovascular death. And one notices that the separation of the event curves occurred very early. Those of you that track cardiovascular outcome trials from the fields of lipidology or hypertension medicine know that in most of these trials, when there is a benefit to the study drug, the emergence of the difference happens somewhere around 12 months, suggesting a potential effect on atheroma. But clearly here, we're dealing with perhaps a hemodynamic effect. It's still not quite clear. We'll talk about mechanisms in just a few slides, but suffice to say that this result not only was very surprising, but very gratifying to many of us in the cardiovascular diabetes field, because as mentioned previously, to date, this is now in 2015, there had been no specific remedy for type 2 diabetes that was demonstrated to have any substantive, consistent effect on major adverse cardiovascular events, let alone cardiovascular mortality. The other striking result from the EMPA-REG Outcome trial, as many of you know, is the effect of heart failure hospitalization, a 35% risk reduction and a earlier event divergence than was seen even in cardiovascular mortality. So since then, again, the EMPA-REG Outcome trial many benefits on MACE and heart failure, as well as some of the renal outcomes that we don't have time to address today. But subsequent studies with canagliflozin in CANVAS showing similar results on MACE, no effects significantly on cardiovascular death, but also an effect on heart failure hospitalization. Dapagliflozin in DECLARE, mainly a primary prevention population, missed the MACE and cardiovascular death outcomes, but did hit the heart failure hospitalization outcome. And the renal study known as CREDENCE had several benefits, both on MACE and mortality, as well as heart failure hospitalization. One of the consistent findings is this 30 to 35% reduction on average in heart failure hospitalization. Importantly, when we dichotomize patients based on the presence or the absence of established cardiovascular disease, this effect in heart failure is consistent. So one does not need established CVD to enjoy the benefits on reducing heart failure hospitalization. Remember that each of these studies, and we'll talk about a heart failure designated study known as DAPA-HF in just a few slides, but the original cardiovascular outcome trials with the SGLT2 inhibitors did not necessarily recruit patients with heart failure. 10 to 14% of the patient populations in CANVAS, DECLARE, and EMPA-REG did have heart failure, but the vast majority did not. Nonetheless, when we re-dichotomize the patients now by the diagnosis of heart failure at baseline, we can see that, again, you have consistent effects, meaning that this drug not only prevents the deterioration of heart failure in those patients with that diagnosis at baseline, but could provocatively actually prevent the new development of heart failure prevention. We looked at this notion in the EMPA-REG outcome trial a couple of years ago, and here we used the Health ABC heart failure risk score. So now we took patients in EMPA-REG outcome who did not have heart failure. These were the 90% of patients without HF at baseline. And we divided them into three groups: those at low to average risk of heart failure based on the ABC risk score, high risk and very high risk. And one can see that there is a not necessarily always consistent, but the point estimate moves in the right direction: 0.55 at very high risk, 0.452 at high risk, and even low to average risk patients, patients that you wouldn't necessarily believe would get heart failure in the future, there was still a 39% risk reduction. The point being that in those patients with type 2 diabetes who are at low or high risk of heart failure or already have heart failure, the drugs appear to be effective. The question is why, and I don't have an answer for you. Is this a volume issue? In other words, is this simply plasma volume reduction because of the osmotic diuresis effect of these medications? There's a bit of a natriuretic function. Remember, the S in SGLT2 inhibitor stands for sodium. Or is there effect through metabolism? Some have proposed that the induction of mild ketogenesis from SGLT2 inhibitors may be a more efficient fuel source for the heart, specifically the failing heart. I think there's lots of different theories, but very little data. The data that we generated from EMPA-REG outcome would suggest a plasma volume reduction effect. This is our mediation analysis that was published a number of years ago, demonstrating that when controlling for each individual covariate, from glycemic, blood pressure, lipid criteria, renal criteria, those of adiposity, nothing seemed to move the point estimate toward unity. If there is complete mediation, the 0.612 hazard ratio would become 1.00, obliterating the effect of the drug after controlling for that covariate. So one looks for the movement of these point estimates toward unity to determine important mediators. And the one that seemed to be the most important were hematocrit and hemoglobin. 50% of the effect of the drug in this circumstance, empagliflozin, 50% or more of that effect was eliminated after controlling for these hematological parameters. And even in CANVAS, this was a later publication, the investigators found something on the order of a 40% mediation. So not dissimilar from what we found in the EMPA-REG outcome. We feel that the effect on hemoglobin, both in the EMPA-REG outcome trial, and then in the CANVAS trial, it is a reflection of plasma volume reduction, i.e. hemoconcentration. Now, there are other theories that the effect on hemoglobin and hematocrit may be mediated through erythropoietin, because investigators have found an abrupt increase in erythropoietin in patients who take SGLT2 inhibitors. I think we don't know for sure whether this effect is being mediated through plasma volume reduction, hemoconcentration, or an increase in erythropoiesis. My own view, it's probably the former, based on new data. This is published by my colleague here at Yale, Jeff Testani, in Circulation. We gave empagliflozin or placebo to about 20 patients with heart failure and demonstrated that the fractional excretion of sodium was modestly increased with empagliflozin, but when paired with a loop diuretic, there was a dramatic increase in the fractional excretion of sodium, indicating an actual synergistic effect when pairing a SGLT2 inhibitor with a loop diuretic. This is the change in blood volume after 14 days and the change in total body water. And I would tell you that this change in blood volume correlates exactly with the increase in hematocrit that has been reported with SGLT2 inhibitors, about a 3 to 4% absolute increase in hematocrit. And finally, there is no activation of the neurohormonal system despite this reduction in plasma volume. So it's almost like these SGLT2 inhibitors allow for a decrease in plasma volume, decrease in preload, decrease in afterload, but without the penalty that one pays when such volume changes are induced by traditional diuretics, such as loop diuretics. So I think we should all agree that the SGLT2 inhibitors, at least for the specific vantage point of heart failure, clearly are beneficial. Now, there was the recent announcement of the VERTIS CV trial at the American Diabetes Association. Here, the fourth in the line of SGLT2 inhibitors, ertugroflosin, was studied in a large classical CV outcome trial. Now, you recall, those of you that viewed the meeting virtually, that there was no significant effect on MACE or CV death, in contrast to the other SGLT2 inhibitors, which at least showed a reduction in MACE, with the exception of, or perhaps the primary prevention, the predominantly primary prevention trial, DECLARE. But even this negative trial did show some hope that the ertugroflosin could be an effective tool in combating heart failure in patients with diabetes, a very consistent reduction of 30% in heart failure hospitalization. Let me quickly update you on the DAPA-HF trial. This is a dapagliflozin study. Patients were randomized to dapagliflozin or placebo. All patients had HFrEF, so heart failure with reduced ejection fraction, and the primary outcome was a classical CV mortality plus worsening heart failure. These were the baseline characteristics of our patients. This is a very typical HFrEF population with an average left ventricular ejection fraction of 31%. And the primary outcome was positive, a 26% reduction in CV mortality and heart failure hospitalization, with a highly significant p-value in favor of dapagliflozin. Both components of the primary outcome were positive, 30% reduction in worsening heart failure. Most of this was heart failure hospitalization, and an 18% reduction in cardiovascular mortality. Interestingly, DAPA-HF recruited both patients with and without diabetes. This was agnostic to glycemic status of the patient, and one can see that the point estimate was almost identical, meaning that patients who do not have diabetes, admittedly most of these patients did have prediabetes, but they were not diagnosed with type 2 diabetes, still enjoyed a beneficial effect from this SGLT2 inhibitor. Now, what about HFpEF? We won't know for another 1 to 2 years. DELIVER is a dapagliflozin study looking at those with preserved ejection fraction heart failure. And then, as you know, the empagliflozin studies, EMPEROR reduced and EMPEROR preserved, are also underway, testing the potential benefit of empagliflozin in those two categories of patients with heart failure. This was the old ADA-EASD guidelines suggesting metformin, then one of the other 6 medications that are in widespread use, progressive double, triple therapy, and ultimately combination injectable therapy. But you recall that there was no data on cardiovascular outcomes when this iteration of the guidelines was last released in 2015, but now we do. So the 2019 guidelines from ADA and ESD specifically mention that after metformin monotherapy, in those patients with established cardiovascular, heart failure, or chronic kidney disease, that specific agents should be considered as primary additions to metformin. If ASCVD predominates, either a GLP-1 or an SGLT2. If heart failure or mild to moderate CKD predominate, then the weight of the evidence clearly points to SGLT2 inhibitors. So let me conclude, heart failure is an increasingly frequent complication of diabetes. It has a very poor prognosis. Glucose control alone does not appear to reduce heart failure risk. Insulin and sulfonylureas also appear neutral on heart failure outcomes. Metformin may be beneficial, but really no RCT data, and TZDs clearly increase the risk of heart failure in patients with type 2 diabetes. In contrast, SGLT2 inhibitors have been consistently shown to reduce heart failure hospitalization rates in those patients with cardiovascular disease and or multiple risk factors, including those with and without a prior history of heart failure. And finally, in the first dedicated heart failure study, the SGLT2 inhibitor dapagliflozin reduced cardiovascular death and worsening heart failure in HFrEF patients, both with and without diabetes. And I think we should all agree that the SGLT2 inhibitors would appear to be the preferred drug to lower glucose in patients with type 2 diabetes and heart failure. Thank you very much for your attention.
Thank you, Dr. Silvio. That was a wonderful presentation. So we'll have a Q&A session at the end. So without wasting time, I'll request for the next speaker, who is none other than Professor Dr. Sasank Joshi. He's a very eminent endocrinologist of India, and he has been the past president of Indian Academy of Diabetes and past president of Endocrine Society of India. And he's also the immediate past president of API and past president of RSSDI. And currently he's the Dean of Indian College of Physicians, and he has been conferred in 2014 the most prestigious Padma Shri Award by the Government of India. So Dr. Joshi will be dealing with management of diabetes with multiple risk factors. So over to Dr. Joshi.
So thank you. I think after Silvio's very elegant talk, I'm going to basically talk about management of type 2 diabetes with the focus on heart failure. Can you just get my slides on board? Yeah. And the focus is heart failure, and there might be a little overlap between his talk and my talk. Can I have the next slide? So, I'm basically going to start with the case discussion, and then from the case I'm going to discuss the contextualization, which Silvio very nicely put, of the role of heart failure in type 2 diabetes, which is increasingly getting recognized, the epidemiology of it, the pathophysiology of it, and then look at prevention of heart failure in type 2 diabetes. Do SGLT2 inhibitors have a role? What is the mechanistic data on it? Some meta-analysis, which he's already alluded to, of CVO outcome trials, and then how the guidelines and the recommendations for management of type 2 diabetes have changed over the last 5 years after the EMPIREC trial. And then, of course, a quick, we nowadays are all staying home, so a stay home message or a summary point. Next slide. So, can you click the slide, please? We are looking at a case of type 2 diabetes mellitus, 58-year-old obese male patient, type 2 diabetes for 2 years, hypertension for 8 years, a bank employee, sedentary lifestyle, smoker for the past 30 years, smokes around 4 to 5 cigarettes per day, occasionally consumes alcohol. Next slide. And patient is now presented. Can you go to the previous slide, please? And you have to keep clicking the slides. A patient presented with complaints of a little bit of fatigue, tiredness, occasional breathlessness on exertion for the last 6 months. That's how I saw him in my office. Next slide. And typically, keep clicking the slide so that you can have the whole picture up there. Pulse was 80, 126 over 80, BMI around 31, no pedal edema, no other relevant findings. The glucose is around fasting blood glucose 186, postprandial 210, A1C around 8.1, LDL around 145. Typically on metformin 1 gram twice a day, metoprolol has approximately 100 milligram per day, telmisartan 20 milligram per day, and rosuvastatin 10 milligram. Next slide. So that's a classical case. And no, please click the previous slide. Previous slide, please. You're clicking too fast. I have told you to click the full slide. So the 2D echocardiogram in this patient revealed a left ventricular ejection fraction at 39%. So that's really the key, that this is a classical case where you can see that there is overt heart failure with the patient is symptomatic and has a compromised left ventricular ejection fraction. Next slide. So what is next? Click the slide, please. Well, we have two goals now. When we manage such a patient, we definitely need a effective glycemic control, but we also need cardiovascular protection. And this is a classical case that of cardiovascular protection. Next slide. So that gets us to the context that how common are people like the previous slide, please. Next slide. How common is heart failure and diabetes? And if you look at the global conundrum, heart failure with diabetes is almost 2 to 5 fold up. We know 65% of deaths due to diabetes are due to cardiovascular disease. The coronary artery disease is around 2 to 4 fold. Stroke is around 2 to 4 fold. But heart failure is 2 to 5 fold. And it is that whole continuum of dysglycemia which actually amplifies the cardiometabolic risk. And there's really no A1C threshold which is apparent. Next slide. So clearly, if you look at this data set, and it's a very elegant data set by A.D. Shah et al., which was published in the Lancet a couple of years back, almost 5 years back. If you look at the first presentation of type 2 diabetes related cardiovascular symptoms, actually heart failure is more common than even myocardial infarction and strokes. So in this study, which is actually a conglomerate, myocardial infarction and stroke continue to be chosen for all the primary outcomes for major types of type 2 diabetes trials as a part of the MACE endpoint. But you can see here peripheral arterial disease is 16.2% as the first manifestation. Heart failure is around 14.1%, and non-fatal MI is around 11.1%. Cerebrovascular stroke is 10.3%, and cardiovascular death around 4.2%. So you can see that whole conundrum is different. And obviously we know that many of the studies now we look at cardiovascular events, we are looking at type 2 diabetes with heart failure and peripheral vascular disease. Next slide. So clearly the cardiovascular mortality matters, and one of the key drivers on outcomes, and this is 1,53,000 plus patients, a large cohort of newly diagnosed type 2 diabetic patients followed for almost a decade. You can see the heart failure has clearly got a large impact on the prognosis compared to coronary artery disease, peripheral artery disease, stroke, or even CKD. So clearly you can see from this clear slide set of Zarneni et al. That heart failure development at any year after diagnosis of type 2 diabetes was having a highest 5-year absolute and relative risk of death and decreases the lifespan within 5 years. So clearly it has a mortality outcome, morbidity outcome, and heart failure is a very poor prognostic marker. Next slide. So obviously the pathophysiological link between heart failure and diabetes is extremely well known, and it's a vicious cycle which sets in, whether it is the energy efficiency, the anabolic function, the endothelial dysfunction, or whether it is the activation of sympathetic nervous system, hypoxia, cytokines, sedentary lifestyle, are all a dual link. Next slide. So clearly if you look at all the studies and the heart failure trials, if you look at the prevalence of diabetes in the heart failure trials with reduced ejection fraction, that number varies anywhere between 15 to 20% of them have diabetes to almost, if you look at the RED-HF trial, almost up to 50%. So anywhere between 15 to 20% to almost 50% people who are recruited of heart failure trials with reduced ejection fraction have diabetes co-prevalent with them. Next slide. Now let us look at, can we make an impact on hospitalization of heart failure with oral anti-hyperglycemic therapy in type 2 diabetes? And that's a question which has been looked at very critically in the last 5 years. As I told you, people started looking at it probably ever since the US FDA mandated in 2008, which now they have taken out, that it's important to look at CV outcomes. And we had data from 2015 which was very supportive. Next slide. So clearly you can see that the old glucose lowering therapy, we know next to nothing about metformin and very limited data on sulfonylureas, though we have some issues, evidences from advance on trials. But a newer glucose lowering therapies, whether it's the gliptins or whether it's the SGLT2 inhibitors, we definitely have some heart failure outcomes on them, both in a concern as well as in a positive direction. Next slide. So clearly you can see a meta-analysis of DPP4 trials, and this is what Sylvia also alluded to, that there was that little risk of hospitalizations for heart failure which came out maybe as a little accident from SAVOR TIMI and Examine. Probably we don't know the truth of it. Maybe it was just a smoke, may not be a signal, but still the FDA from the US has still put a little bit of a box warning. A little tad unfair after TCOS data and probably after the Carbolina and Corlina data. I feel it's a little unfair, but that is still there. But they were MACE safe, so they were CV safe. They had a challenge with heart failure. Next slide. If you look at the cardiovascular outcomes from the Carolina trial, again you can see clear data to show that there was a no suggestion coming out on the heart failure hospitalization risk, which was very similar between both the groups. Next slide. And you can see that if you look at different SGLT2 inhibitors on the cardiovascular study cohorts, if you look at EMPA-REG, it's all secondary prevention. If you look at the CANVAS program, it's 1/3 and 2/3. If you look at DECLARE TIMI58 with DAPA, it's probably 2/3, 1/3, or 60%, 40% when we are looking at people with various CV studies cohorts. Next slide. So obviously when you look at the MACE outcomes, clearly you can see the verdict was very clearly positive. Next slide. Except for DECLARE TIMI, which was neutral. So clearly we know that the EMPA-REG patients, the placebo events were high in EMPA-REG in all subjects with prior CV event, whereas they were lowest in DECLARE, where there were more subjects with the multiple risk factor group. And that's why there was some meaningful difference in the MACE outcomes, which has been amplified here. Next slide. Clearly, when you look at hospitalization of heart failure in presence of atherosclerotic cardiovascular disease, DECLARE TIMI had a very clear-cut hazard ratio of 0.64, which is self-explanatory. Next slide. In the MRF group, and if you look at the history of prior heart failure, again the data from DECLARE TIMI58 with DAPA was pretty clear-cut. Next slide. So obviously DAPA has evidence that heart failure prevention with diabetes, both with history of heart failure and without prior history of heart failure, was reasonably clear-cut, and that data set has been consistent. Next slide. So obviously when you compare, do we have data in the RCT database where we compare two SGLT2 inhibitors, and we don't have that, but we do have some real world data from a multi-institutional cohort study which compared EMPA users versus new users of DAPA and found that probably there was a hazard ratio of 0.68, and probably there was a suggestion that DAPA might have a little lower risk of heart failure. Obviously it has its own limitations, but it's a real world data, and it's in public domain, which has been published last year. Next slide. So obviously there is a clear directionality to how SGLT2 inhibitors work. My previous speaker Silvio has very clearly told you that there is a sodium hydrogen exchanger, there is a calcium RY/R2 activity, with definitely the afterload, the preload, the diuretic pathways, the natriuretic pathways, the glycosuria pathways, the myocardial energetics, the beta hydroxybutyrate impact on the mitochondria, the adipokine issue, the inflammatory issue, the glomerular impact. All these are very clearly there. So there's a metabolic diuretic promise of SGLT2 inhibition, and definitely we are in search of that sweet spot in heart failure, and clearly they work, and they clearly work probably in heart failure too, and probably they might work even in non-diabetic heart failure. That's something which we now know a little better in the last 1 or 1.5 years. Next slide. So clearly we also know the deadly link between heart failure and kidney damage, and we know that again this is a very clear cut there. When there is heart failure, when there is a compensatory mechanism of increased venous pressure, sympathetic nervous system activation, natriuresis, there's worsening of heart failure, that's like it's again an amplifier effect, worsening of kidney failure, worsening of heart failure with hypoperfusion, apoptosis, fibrosis in the kidney, renin-angiotensin system activation with sodium and water retention, vasoconstriction. So obviously a bad cascade is set up by the links between the kidney and the heart failure. Next slide. So obviously now we also look, these are not just cardiac agents, but they're also renal agents, and the data on that is excellent. You can clearly see that on renal related composite endpoints, the hazard ratio is pretty significant, where declartimine 0.53, canvas 0.6, and empiric 0.54. Next slide. And in presence of atherosclerotic cardiovascular disease, clearly with multiple risk factors, again you can see with declartimine 0.51 hazard ratio, which is pretty clear cut. Next slide. So obviously when we look at effect of DAPA on the risk of fast decline of eGFR, clearly we know that DAPA reduces the risk of fast decline of GFR in a broad population of type 2 diabetes, either with established cardiovascular disease or those who are at risk with cardiovascular disease. So it definitely has a larger coverage on overall patients compared to the narrow established CVD which is seen with the empiric trial. Next slide. So obviously Subodh Verma, who's a cardiac surgeon in Canada, wrote this very nice paper of pumps, pipes, filters, do SGLT2 inhibitors cover it all? And probably they do. We know this very well, that whether it's the multiple risk factors or whether it's established cardiovascular risk factors, SGLT2 inhibitors in primary prevention prevent heart failure and renal disease. That data is pretty clear cut. But they may not reduce the major adverse cardiovascular events. So from a primary prevention perspective, SGLT2 inhibitors have data to support HHF and renal outcomes, but may not have the 3-point MACE data. While it comes to secondary prevention, SGLT2 inhibitors prevent heart failure and renal disease, reduce atherosclerotic events as well. But this is again in a time where the Vertis trial data has not been taken in for this consideration, which was presented a couple of weeks back, and that has its own challenges. So we know every SGLT2 inhibitor has some granularity and difference which we need to teether out. Next slide. So MACE data is clearly there for secondary prevention. Next slide. And HHF data is pretty universal, secondary and primary both. Next slide. And renal protection is also pretty clear cut. Next slide. So obviously there has been a huge impact in the last 5 years that virtually, management of heart disease and management of diabetes have often got blurred, and various cardiac societies and global diabetes societies have often merged their guidance and recommendations, though there have been some unfair allegations that they may have been too aggressive, but the data has been compelling. When you have compelling data, then you come out with some compelling recommendations, and that compelling data was because we never had so many positive CV outcome data as much as what we got in the last 5 years. Let's look at some of these guideline strategies. Well, this was the EDA 2020. It's a live document. It keeps on getting updated with all the novel things. If it's very clear cut that if there is atherosclerotic, established or high risk disease, CKD or heart failure, clearly SGLT2 inhibitors are right up there. When atherosclerotic vascular disease promotes, then we can look at using a GLP-1 receptor blocker with a CV benefit, and SGLT2 inhibitor also with a proven CV benefit. So that data is pretty clear cut. Next slide. When you look at the ESC, click the whole slide. ESC, ESD guidelines for diabetes, pre-diabetes, cardiovascular disease. Well, they have got more aggressive because they say don't even use metformin. If somebody is very high risk, click the slide please. You can actually aggressively use this, and they have clearly recommended that for high and very high risk patients, SGLT2 inhibitors or GLP-1 may be considered as a first line therapy. So they probably, the European Society of Cardiology and European National Study of Diabetes has got little more aggressive than the ADA. Next slide. And clearly DAPA has got that compelling evidence where it comes to both the impacts of patients, people with multiple risk factors, as well as established atherosclerotic cardiovascular disease. Next slide. So obviously managing this case, what did I do? I just switched the patient to a dual therapy of metformin with DAPA. I given the dose of 1 gram sustained release twice a day with the meal, and started with 10 milligram of DAPA for 1 month, and followed up the patient after 3 months. Let's look at the data set. Next slide. You can see the glucose and the A1C has come to 7.4, blood pressure is better, blood weight has come down to 1.8, and obviously we continued metformin DAPA again and looked at the patient again after 3 months. Next slide. And you can see the A1C is down to 6.1, blood pressure is much better, weight loss of 3.1 kilogram, and clearly you can see that there is a very substantial difference. These are game changer drugs and clearly have some compelling piece of evidence. We are not just saying it because there is some push from A or B, but they have some compelling evidence which is there in the RCT space. as because we are in an era of evidence-based medicine. Next slide. So obviously this is my final slide, and my whole idea of using a case example was to show that diabetes now is a very clear-cut risk factor, not just for cardiovascular disease in general, but also propels the risk for heart failure and cardiovascular death. We know comorbidities of diabetes often have hypertension, dyslipidemia, and that propel the risk of heart failure much more in diabetic populations. I did allude to DAPA because it does have some role in preventing heart failure in diabetic patients, especially those with multiple severe risk factors. And there's some more compelling data in the non-diabetic space also, which I did allude to because we are focusing on diabetes today. And dapagliflozin has shown CV benefits in preventing hospitalization of heart failure, cardiovascular death, both in diabetic population and non-diabetic population. And if we use SGLT2 inhibitors appropriately in type 2 diabetic patients with cardiovascular risk factors, clearly we can have not only clinical outcome, which is better, but we can make a cardio-renal impact and minimize and mitigate complications, whether it's in primary space or in secondary space. In the primary space, it's predominantly renal and heart failure hospitalizations. In the secondary space, of course, we have the MACE data to back it up. Thank you for a patient hearing.
So thank you, Professor Joshi. That was a wonderful presentation. So we have another 15 minutes for Q&A, and so we have discussed, Dr. Silvio and Dr. Joshi has discussed nicely about heart failure and diabetes and how SGLT2 inhibitors are beneficial in this aspect. So my question to Dr. Silvio and to Professor Joshi is it a class effect for all SGLT2 inhibitors regarding heart failure? And we have all seen about evidences about heart failure with reduced ejection fraction. What about heart failure with preserved ejection fraction? Though the evidences are evolving or the trials are on the way, so how it should unfold actually in future?
Maybe I will start. So I actually do think the heart failure is a class effect. You saw that in the Virtus CV study, even though it was a neutral study overall, there still was a 30% risk reduction. So I've not seen any statistical differences between the four SGLT2 inhibitors. As regards to heart failure with preserved ejection fraction, I think people get into trouble when they try to predict what will happen with that condition because, as many of you know, certainly the cardiologists today know that heart failure with preserved ejection fraction has been difficult to demonstrate at least a mortality benefit from many of the therapies that have been proven to work in heart failure with reduced ejection fraction. I predict that the SGLT2 inhibitors will be the first drug to demonstrate that difference because of how it works in terms of the plasma volume reduction. But we really won't know for at least 1 to 2 years when Emperor preserved and deliver are released.
So I think my answer, I would agree with Silvio. If you look and keep waiting for evidence, probably the evidence will come in that direction. But I think if you look at from a mechanistic standpoint, it is reasonable to presume that whether it is preserved ejection fraction or whether it is reduced ejection fraction, the data for reduced ejection fraction is clear cut. In preserved ejection fraction, probably there might be data which may come up. But you know, these agents are also competing with other heart failure agents. So in the heart failure armamentarium, from a cardiology angle also, you will see that these agents will have a place. Currently they are having limited space, but I see that within a year and a half, you will see a larger expansion of that phase in the cardiology forefront. And that's clearly there. Also in the nephrology space, it's not just going to be restricted to heart disease. I personally feel that these agents will also be increasingly used by nephrologists. Currently we have the eGFR cutoffs. The eGFR cutoffs are stuck at 45 and 30 and 60, but I will see that those eGFR setups and cutoffs will come down a little bit in clinical practice, because I think the clear-cut compelling data which is emerging is on not only just heart failure reduction but also on the renal protection, and I think these two are clear. The directionality is very clear, and I think it's predominantly class effect. I doubt even the Virtus CV had the heart failure. HHF is clear cut. I think everywhere else there could be challenges. It was a little disappointing to see those numbers, but you know, this is these are hazards of evidence-based medicine, so sometimes you often get surprises, and it's a neutral trial. It met its primary endpoint, but I was disappointed with the numbers.
Maybe the MACE was not a class effect and heart failure as a class effect. So
I think they didn't include Asian population, because if you
right.
see what drove the EMPA-REG population, the Caucasians are not as sensitive to these agents as the Caucasians are not as sensitive as the Asians are. So if you look at the racial split, of all the trials, you can see that the Asian population probably has a more robust outcome data. If you look at, just clearly divide the EMPA-REG between Asians versus Caucasians, actually Caucasian data set turns out to be neutral compared to the Asian data set. And if you really dissect, of course you can't dissect it that way because that's not the way the trials are designed. But if you actually hair split and if you go into the appendixes of all these articles and the fine print, that's how you can see that. And we often do that. So, but I think I'm still disappointed. Maybe Sylvia might have another opinion on it, and I would love to know his opinion on what is CV. But clearly, I still feel the heart failure data is pretty clear cut. I think that's something that still was there, but the rest of the trial, it had a similar cohort like EMPA-REG, and still it came out with a different number. So Sylvia, what's your comment on that?
Yeah, even more patients with heart failure. They had twice as many patients with heart failure, so I would have anticipated even greater effect. You remember the MACE effect of these drugs is pretty modest, right? So there's 14% with Cana, 14% with EMPA, and I think it was 9%, which was not statistically significant, either 7 or 9%, I forget, with Declare. 9%. Yeah. So, you're dealing with very modest movements of that point estimate. And eventually, if you do enough trials, you're going to find a study that is close to 1.00. But the heart failure effect is so huge that even if there's differences between the drugs, each of the drugs are going to show a benefit. I was more disappointed in the renal outcome because that was just 18%, was not statistically significant. Now, they did not include macroalbuminuria. It was a so-called hard renal outcome. But when you look at EMPA-REG, the hard renal outcome was even larger than the overall renal outcome. I believe it was, the hazard ratio was down to 0.54, 0.55. So that's the aspect of Virtus that I cannot explain. The MACE effect doesn't bother me because the other drugs are relatively weakish, shall we say, on MACE, and heart failure is consistent. So
there are a few good questions coming up from audience. So one of a very tricky question to Professor Joshi is that among SGLT2 inhibitors, which SGLT2 inhibitor would you prefer to use in which specific conditions?
So you see, if you ask me very honestly, the data, as Silvio very rightly said, for 3-point MACE is modest, with heart failure is clear cut, with kidneys clear cut. We have all the agents which are available. Heart failure, probably the data on DAPA looks more robust. On a larger population, probably the data on DAPA looks more robust. EMPA has data more in the severe or established cases. Cana is probably stronger, but has that little outlier of amputation still hanging up there. Though Credence and all didn't have that, but it's still hanging up there, So it's not gone completely. Though I think it has got mitigated to some extent. So those are the three we have. We have Remo with us, which is cost effective, and it's right off the block. So we have 4, and we might get ER2 in times to come. Among all the 5 agents, probably ER2 has been a little disappointing, but I think they all are similar in terms of efficacy. Safety needs more dilatation, and in terms of heart failure impact and a broader population being covered, probably DAPA has little more robust data than the others. And we will have to wait for, as Silvio said, for a year and a half for seeing the data on the preserved ejection fraction data which will come. I think EMPA, Cana, DAPA, there's very little to choose, but DAPA probably has that little advantage on a broader population. EMPA has some very strong outcomes like CV death, etc. So it's not an easy choice to make as a clinician. Like the case which I presented to you was pretty obvious, so I made the choice of DAPA. So it's not something which maybe Silvio probably would have chosen EMPA. Silvio, I don't know how he would have seen in his practice in Connecticut. I don't know how he would have seen that.
The choices the choices here are mainly driven by which formulary restriction the patient has in terms of their insurance. So the EHR kind of drives you toward one or the other drug. So what we think biologically doesn't make as much difference here.
I think, thank you. So another important question is asked by one guest that we have always a concern about use of diuretics with an SGLT2 inhibitor in heart failure, because we know that cardiologists use very high doses of loop diuretics in heart failure, and that may actually reduce, or the patient may be in a little bit dehydrated state. So giving an SGLT2 inhibitor is a little bit tricky situation. So what's your take on that, Dr. Silvio?
So we actually have some data from JPEF. This was a heart failure study. So vast majority, I think 90% of our patients were on some type of diuretic, most of those being loop diuretics. And actually, when you look at the changes in diuretics, increases in the placebo group and decreases in the active therapy group, they were very, very modest, something on the order of 10%. There was no mandate to reduce diuretic dose. So our recommendation is that if the patient is fluid overload at baseline, add the SGLT2, don't touch the diuretic. If the patient contracted at baseline, adjust the diuretic when you add the SGLT2 inhibitor. And if the patient is considered euvolemic, add the SGLT2 inhibitor. Do not adjust the diuretic, but follow the patient closely.
So just a continuum of that question to Professor Joshi. Now, a question is being asked whether ARNI can be used with SGLT2 inhibitor, or ARNI is going to be replaced by SGLT2 inhibitor. So in heart failure.
So this is often asked question. So one thing is when you use ARNI and a DAPA like together, you need to have both the doses, and you need to monitor electrolytes very closely. But there is compelling evidence that in times to come, I am seeing our cardiology colleagues are increasingly using more and more SGLT2 inhibitors, and their need for use of ARNI is going down. ARNI has its own space in the heart failure space. Mind you, these are chronic heart failure drugs. These are not acute heart failure drugs. And I think in the chronic space, you will see a lot of co-prescription of both these agents, but at half the doses most of the times. But I think in another year or year and a half, you will see a lesser use of ARNI and a larger use of SGLT2 inhibitors in the cardiac space, particularly in the chronic heart failure space. Silvio?
Yeah, so we just published the combination subgroup in JPEF. So we had a few hundred patients that were already on sacubitril valsartan, and the benefit of dapagliflozin was similar. There was no difference and no increase in adverse events. Now, obviously, this is an expensive undertaking, right? Both an ARNI as well as an SGLT2 inhibitor, but at least medically, biologically, there appears to be complementary effects. One does not mitigate the benefits of the other.
Correct. So one question which was asked is DAPA reduced the new onset of diabetes in DAPA HF trial. So can you find a place of DAPA in prevention of diabetes in future? So Dr.
I'll start. Maybe Dr. Joshi will have a comment on this, but I think that diabetes prevention is lifestyle change, right? We can't get away from that. That's very, very important. It has a huge effect, a 58% risk reduction, at least in the DPP, which was the largest diabetes prevention study. I think that pharmacological therapy is of great interest to endocrinologists, because we're always looking for an effect of a diabetes pill or a obesity pill to reduce diabetes prevention, to reduce the incidence of diabetes, especially in higher risk patients with pre-diabetes. You mentioned that in DAPA-HF, we did demonstrate a prevention effect. Now, with the disclaimer that this was not a diabetes prevention trial. We did not do fasting glucoses. We did not conduct oral glucose tolerance testing like you might in a traditional diabetes prevention trial. We did have hemoglobin A1C with all its potential problems in interpretation. But based on hemoglobin A1C, the reduction in new onset diabetes was 32% over the course of 18 months, which compares favorably to metformin, which is widely viewed as a reasonable diabetes prevention drug. You remember that the risk reduction in DPP was 31%, so almost identical effect. So this is a heart failure population. They did have some improvement in their quality of life and exercise capacity. So you could say that it's the heart failure effect that is driving the diabetes prevention, because they're moving around more. We don't have that data. So I'm interested in this space, and I think a larger trial should be done in a traditional pre-diabetes population, but I don't think we should go out and prescribe these medications wantonly to prevent diabetes.
Correct. So we have another just last 2 minutes. So the last question to Professor Joshi, one question is being asked that ESC, ESD guidelines have actually taken SGLT2 inhibitor above metformin, and in patients with SCVD, you can use first with SGLT2. So what's your take on that? So should we replace
So
metformin?
absolutely, I think in fact Silvio just said that they're competing with metformin for pre-diabetes space, though that's not a suggestion. But I think that only moves the treatment arm that the evidence base on these agents are stronger than metformin. Metformin evidence base is not that strong. It's very weak evidence base on which it became the first line agent. I think the evidence base on some of the new age agents like DAPA is pretty compelling. And if you don't want to use it in pre-diabetes, which looks to be a little exploratory at this stage, but I think certainly as a first line agent, it's a good option to use. And I think if it's used appropriately and carefully, it's and with the high risk or very high risk patients, I think it's pretty justified. So I think the ESC and ESG have not been overzealous. They have looked at data, they have looked at evidence, and based on that, they have made a recommendation. I agree with Silvio completely that in pre-diabetes space, it looks attractive, but you can't replace lifestyle because the messaging will go wrong. See, that's a public health space, domain space. It's not really a medical domain space. So in the medical domain space, it's different. And then you have the issues of reimbursement and issues of cost. So lifestyle still will stay there, but I think DAPA has a very attractive option, and probably it will have a space probably in pre-diabetes, but certainly in early diabetes. So I think this data set of diabetes being prevented in that subset actually gives more credence to the theory that you can use it early, particularly in the high cardiovascular risk setup. And I think it will save lives. See, at the end of the day, every 7 seconds we are losing a diabetic on planet Earth. Do we have any medications which can lengthen the lifespan of a diabetic? On an average, if you take a diabetic lives around 7 or 8 years less or a decade less than normal people. So can these agents actually increase the lifespan of a diabetic? Probable answer is maybe yes. At least we have a direction. We need to do large prospective outcome studies on the lifespan of a diabetic with these agents. But whatever little we conclude from mortality data from CV outcome trials, I think, and now the CV outcome trials will again shut out because the way US FDA has put it out, the number of US FDA related trials will also come down. I think we'll not see so many trials now happening. We have some answers, and I think there will be a role. That's my take on it.
Thank you, Professor Joshi, Professor Silvio. That was a wonderful discussion. And with that, we'll end the symposium, the Heart Failure and Diabetes Symposium. Thank you all.
Thank you very much.
Bye-bye.
Bye-bye.
Thank you. Bye-bye.
Thank you, sir. Thank you for giving the time. Thank you, Dr. Silvio and Dr. Shashankar Joshi for such a comprehensive session, and also thanking you, Dr. Sambit, sir. We are moving on for the next session.
Of inflammation, we are prone for
more acute coronary syndrome because of new vascularization. We are prone for vasa vasorum enlargement. Sometimes the plaque rupture may start from outside to inside, and more collagen layout that causes more restenosis. So diabetes has got a very complicated problem. You are more prone for developing acute coronary syndrome. At the same time, these interventions do not last long because of neovascularization. Another very interesting thing to look at it, the microvascular involvement. If you have one microvascular bad involvement, the the risk is so much. If you have two, then three, then there is a correlation that number of vascular bad in microvascular compartment, more the number, more the poor outcome. And retinopathy is almost always associated with nephropathy. These two compartments, they go hand in hand. But the story doesn't add at microvascular compartment because we have a macrovascular compartment involvement also. If there are polyvascular disease, what we call as cardiologist, if you have diabetes, stroke, and MI, on top you are the worst. So the moment disease become in macrovascular, polyvascular, that means if you have peripheral arterial disease, cerebrovascular disease, or coronary artery disease, what we define as polyvascular disease, we are in great problem. And if we both have micro and macrovascular disease, then the trouble is not double, it is many, many fold. And looking at it, a very simple diagram, which all of you know more than what I know, if there is a microvascular compartment which is debilitating, not life-threatening, is glycemia related, but it is preceded by macrovascular compartment complication. So if you have a patient who has got microvascular compartment, I strongly feel these are the patients whom we look for macrovascular involvement. And we should never miss this stage. Another very good understanding that even patients who are children born out of diabetic parents, even if they are normoglycemic, their endothelium-dependent vasodilatation is poor. That means the vascular compartment involvement starts even before dysglycemia. And this is the summary why cardiologists are poking their fingers into diabetes, because whatever you do, whichever way you do deal with these patients, the diabetic patient do worse than their non-diabetic counterpart. So that is a big challenge to diabetologists and cardiologists or a vascular biologist, because that is how we have to make that a non-diabetic patient in their vascular compartment should become non-diabetic. And I am very honest that till today we have not been able to achieve it. With this background, let us go for searching this sweet spot for CV risk reduction. And the story begins now, how we are going to deal with it. You know, there are various mechanisms. Glycemic control is one, but what has happened best is in 2008 with rosiglitazone story, the FDA has given us a mandate that patients should not be controlled only on diabetes, but they should be controlled in terms of vascular compartment. This is guidance to the industry in 2008, and there we started a new era called glucocardiac-centric era, or a vasculocentric approach to diabetes. That is why we are here to play and interact with you, because we have to see how we can deal this problem jointly. And there are two studies, LEADER and EMPA-REG, each one of you know. And this is a follow-up for 3.8 years, it is 3.1 year. My interest is this. Prior CVD was present in 81% of the patient, while it was in EMPA-REG, 99% of the patient, roughly about 20% of the patients in LEADER are not vascular patients, which were there in EMPA-REG. So there is slight disadvantage to LEADER in terms of atherosclerotic burden to outcomes, because had LEADER been something like EMPA-REG, 99%, I will say, I believe that the result of LEADER would have been more powerful than what we have today. And this is a very important slide. It shows inconsistent directional discordance. You see the stroke incidence increases in EMPA-RAG, and while it is consistent directional concordance. So we know that in EMPA-RAG, there is slight dissociation between vascular VAD and a coronary VAD, while there is a concordance in leader. That is a very strong point to carry home. Another good thing is the EMPA-RAG, the result, they start within a month or two, they start separating out, but in leader, they start significantly at 1 year or so. And those who follow lipidology, they know that is how statin trials behave. They do not behave that these curve, they start separating within weeks or months. So this is some kind, SGLT2 inhibitors are some kind of neurohumoral modulator, if you permit me to say, like apleneron. But leader is behaving, liraglutide behaves on atherosclerotic compartment, something like statins, because they work on atherosclerotic compartment, which start separating out a little bit late. And when we compare these drugs, liraglutide, empagliflozin, and sacubitril/valsartan, there are 3 new molecules. We find these drugs, they stand the test of time, and they are comparators to each other, complementary to each other. They are not competitive. Look at the all-cause mortality, look at the CV mortality, look at the sudden cardiac death. They are all favorable, both liraglutide and the EMPA-RAG. So I'll say this drug is comparator to rest of its newer friends like empagliflozin and sacubitril/valsartan. This is a new study, Swed-Heart study, where they have shown patients who were given liraglutide in hospital, they start separating out fast within 6 to 8 months, and they continue to diverge like a crocodile mouth. So this is a real world data which shows liraglutide, when used in acute MI, it works wonderfully well. Liraglutide improves the infarct size after ST segment elevation. It causes less of reperfusion injury, even in non-diabetic patients. So we are in an era like EMPA-RAG in non-diabetic heart failure. Similarly, we are getting some signals that liraglutide can affect the vascular compartment even in non-diabetic patients. It improves the infarct size. This is a global increase in LV ejection fraction. There's liraglutide and placebo, those who are going primary PCI, justifying that liraglutide is affecting the vascular compartment positively, even in acute coronary situation. The situation for SGLT2 inhibitors is not same. There is not much data. There are consensus opinion that it can be used in acute MI, but most of the time the drug is allowed to be used post-discharge. But unlike that, liraglutide can be used during in-hospital acute coronary syndrome. This is another study which shows that type 2 diabetes mellitus, with or without established cardiovascular disease, they both have favorable outcome. This is just 2020 publication. So again, going and extending that, if you are high risk for developing coronary artery disease and diabetic, liraglutide can be used safely with outcome benefit in a patient who have not expressed disease. This is a summary from McMurray and Christensen, appeared in Lancet last year late, and it showed that liraglutide, when the GLP-1 receptor agonist, not liraglutide specifically, they do benefit in all the outcome related parameters. Just see. If we look at the 3-component MACE, if we look at the cardiovascular death, if we look at the fatal, non-fatal myocardial infarction, fatal, non-fatal stroke, all p-values are significant in this meta-analysis. And this is very, very reassuring. Another way to look at it, all-cause mortality, hospital admission for heart failure, composite kidney outcome including macroalbuminuria, worsening of kidney function. Again, the p-values are significant, although largely the volume of data is in favor of SGLT2 inhibitors if we have macroalbuminuria and renal EGFR issues, they have more volume and more strength, but in this meta-analysis, they have equally performed well, all GLP, when we take into consideration. This is a heart failure study. There are short trials. Unfortunately, they both are associated with increase in heart rate, and these trials, LIFE, FIGHT, and LIRA heart failure 2D, they have not shown advantage in heart failure. So I'll stretch myself in saying that in heart failure, the meta-analysis has shown advantage, but largely my choice of drug will be SGLT2 inhibitor, not GLP-1 receptor analog, but they are not harmful in heart failure patients. This is another study, and you must have seen that since it increases the heart rate, this is subgroup leader study again, that patients who have 10 beat per minute increase in heart rate, there is no difference in MACE and hospitalization heart failure. So heart rate does increase with liraglutide, but the outcome is not different. That is just about a couple of days back. This is number needed to treat, a temporal analysis, and this is again a very good study to see that number needed to treat keeps on decreasing once we follow these patients for longer length of time. And this is what you see, that number needed to treat keeps on decreasing. Number needed to harm initially is low, but as we follow 3 years across, it is roughly around 150, which is very, very satisfying. If you look at the blue at leader, number needed to treat keeps on decreasing over a period of time, although the liraglutide was 3.8 years, but this is a projection that this will be the likely number needed to treat. So it is assuring that over a longer follow-up, these molecules are going to give us better outcome rather than decrease, and number needed to treat keeps on decreasing. So to summarize, that SGLT2 is more on pump, and GLP-1 receptor analog more on ASCVD pathway, and that is, I think, is more of a consensus. So the mechanism behind these drugs are multifold, and since these drugs are new, we are not really sure that everything we know is good or bad, but there are some understandings which we have to listen to. And you can say it decreases body weight, blood sugar, blood pressure, and lipid metabolism, and it is how, and what is next we are trying to learn is the inflammation. And these risk reduction are independent of metabolic parameters. So there is some kind of pleiotropism. We have to understand that they are not metabolic or glucose reduction properties which are translating into the outcomes. And this is a summary how we look at it, what we achieve. And this is a reduction in systolic blood pressure with liraglutide. And this is a brief report which shows that the effect of liraglutide and in sustained 6-semaglutide are independent of baseline blood pressure. That is again very, very important thing, that the outcomes are not related to the baseline blood pressure. I'm actually getting, this is a slide which I wanted to show, a very recent publication, that the outcomes are unrelated to the baseline blood pressure, both in terms of systolic and diastolic blood pressure. This is the effect on lipid profiles. And so the next issue which has come up to our understanding is inflammation. And that is a very hot thing in cardiology because residual risk can only be addressed by inflammation. It reduces preclinical evidence of anti-inflammatory effects of GLP-1 receptor analogs in labs, and we have some evidence in clinics also. This is the upcoming trial which will do FDG scanning of a hot plaque, and we will be able to see whether the inflammation is reduced in vivo. It is not in vitro. In vivo, whether we are able to reduce inflammation in a plaque. This is all the biomarkers. You can see that they are reduced favorably, and that is how probably it works. This is summary of the effects, that there are multiple ways. When you have many ways, probably we have multiple ways, multiple pathways, and many of them are still unknown. The molecular mechanistics are very simple. When they work on the gut, they reduce inflammation, they reduce lipid deposition, they decrease plaque lesion development, decrease inflammatory pathway, and that is why they are very important asset in dealing with atherosclerosis in diabetes. This is many direct effects. GLP, these receptors are more expressed than SGLT2, so their effects are more systematic than the SGLT2, which are confined to less vascular bed, predominantly to gut and kidneys. This is a low burden of atherosclerosis development when liraglutide inhibits progression of the atheroma. The only thing which I am going to show is that it causes increased sympathetic system activation where there is no activation, and increase the heart rate. That is one thing which we have to keep in mind. And these two molecules are complementary. They are not competitive. They are working on two different axes. That's why we should not carry away there is a conflict between these two molecules. And there is a host of new investigations being done to understand that how GLP-1 receptor analog can work in HIV, osteoarthritic, chronic obstructive lung disease, liver disease, Alzheimer, tobacco dependence, alcohol dependence, craniopharyngioma, because they are expressed in brain also. This is an algorithm which is very recent from American Society of Nephrology, and I think it is a very comprehensive, very simple, and it is ready to use for us. If you have diabetic kidney disease, eGFR is more than 30, you go to SGLT and then add on. If the eGFR is less than 30, probably GLP-1. High risk of heart failure, yes, you go for SGLT2, but they are not harmful in the presence of heart failure. If you have ASCVD, you can go for GLP-1 earlier than SGLT2. If you have UACR more than 30 SGLT2, if it is less than 30, then it is GLP-1, because their albuminuric effect, hypoalbuminuric effect are less pronounced than SGLT2. If you have metabolic risk, again, the GLP-1 receptor analog are preferred. If you have none of them, they are probably not recommended. I think, to my mind, this is the most simplistic and clinical approach to use these molecules, and I find there is no conflict between the two molecules. So again, showing that if GFR is less than 15 to 30, then GLP-1, they are drug. Otherwise, if albuminuria is more than SGLT2, then this is the way we look at it, and simplistic I have expressed you. The use of glucagon-like peptide receptor, this is again a very recent publication, again saying that these drugs are complementary, and they can become partners in managing vascular nuisance. So establish atherosclerotic disease, cerebrovascular disease, eGFR less than 30, then we will go for GLP-1. And if the complications, they trouble you, comorbidities, obesity, frequent genital mycotic infection, osteoporosis, history of fracture, lower limb ulcer and amputation, probably this will be our drug of choice. So I find there is no conflict. They are complementary. This is update, you know more than me, and they also say that if there is atherosclerosis, probably the GLP-1 receptor analog liraglutide is a better drug to be used. This is recommendation that patient with type 2 and establish atherosclerotic CVDCs. And that is what is going on, that in a metformin naive patient, there is an emerging consensus guideline directed opinion that you can display GLP-1 receptor analog as a first drug to tame the vascular compartment problem. This is navigating through the maze. Again, GLP-1 receptors are predominantly specific to atherosclerotic CV events, non-fatal MI, stroke, and death. By contrast, they have significant effect on non-fatal MI. They do not have effects on non-fatal MI and stroke. That probably the myocardial pump, they affect more, and the pipes are affected more by GLP-1 receptor analogs. They are both class 1A indications. Now, this most important issue, what my panelists said, that why they are not being used, who will bell the cat? I think this is the responsibility of cardiologists, endocrinologists, and more responsibility of us, because patients.
Excuse me, sir, we have only 2 minutes left.
Yeah, just I am winding up. So instead of using therapies which diminish return, like if you see 3-fold more likely to get DPP-4 inhibitors, 7-fold more likely to get sulfonylurea, and 8-fold more likely to win like insulin, despite having such a strong indication of being used, we are underperforming. They are like statins, they are like antiplatelets. They have to be used very aggressively, and once again saying they are complementary to each other. And the usage is both in UK and US is less than 10%, and that is why this Gold Symposium encourages us, shows our responsibility that physician inertia is to be handled, and we have to use them more liberally so that a community is benefited. And this is Dr. Braunwald, who is a father figure in cardiology. So now he challenges that cardiologists have to learn more of diabetes, because the vascular compartment can only be tamed if we use good anti-diabetic drug. And he has coined a new term which is called diabetocardiology. I'll just wind up on this, that the lifestyle modification continues to be very, very important. And GLP-1 and SGLT2 inhibitors are not competitive. They are not conflicting. They are cooperative to each other and complementary. And we have to profile a patient where which drug comes first, and probably the second drug will automatically come later on. And that is probably the need of the hour. And we have not to forget that these drugs should never be missed, underused, and they should be given, displayed to our patient population as much as possible.
Thank you very much, sir, for that session. For the next, to invite the next speaker, I am inviting Dr. Anand Pillai, sir. Anand Pillai, sir, please.
Hi, thank you. First of all, thank you, Dr. Rajiv Agarwal, sir. Am I audible?
Yes, you are audible.
Okay, great. A very exhaustive update on SGLT2s and GLP-1 analogs, particularly differential indication in terms of cardiac and renal, when to pick which drug. Thank you so much, sir. I think we'll come back to you with the panel discussion. Next, I would like to invite the next speaker is Bhattacharya, sir, from Bangalore. Sir is a consultant in the Department of Diabetes and Endocrinology, MHB, Professor of Endocrinology, JJMMC, Devangiri, Karnataka, as well as co-chair of Shiva Jyoti. Sir will be talking to us on addressing the elephant in the room, therapeutic inertia in comprehensive management of diabetes.
Thank you. Can I share my screen? Is that full screen you can see now?
Yes, sir.
Just a minute. Let me just get my. This is a half screen. I think you can see. Why it is not moving?
Yeah, it is visible. It's a full screen.
Yeah, but there's something is coming. It is correct. I need to go to the share screen again.
I'm not sure if it was shared by you or from the JPEF main media board.
Yes, sir, we have shared it.
Okay.
Now the full screen.
It is in full screen, sir.
Okay, fine. Thank you. Thanks very much. Namaskar. I'm Dr. Bhattacharya from Bangalore. I'm Jyoti must have, thanks Dr. Anand. We have a lot of positive points taken from Rajiv. Jothydev thought that I'm very strong man, so I'll take the big elephant outside the room because elephant is very heavy and it requires something big, big input. So my idea of taking further about the GLP-1 receptor analog, that's what the topic on therapeutic inertia and how it can help. This is some of my disclaimer. I did participate and I do participate till now on the clinical trials in the different phases with the different anti-hyperglycemic agents, including insulin, GLP-1 receptor analog, and IDEG-ASPERT. We did work with clinical development program of liraglutide. I'm a member of some ad hoc companies, but I don't have any share in pharmaceutical company. I take the responsibility of the text of my talk, and our focus today is on GLP-1 receptor analog. So I'm going to take how it can take the elephant away. Okay. The thing about the webinar is that it doesn't have any take-home message since you are already at home. But I'm sure after listening to Dr. Rajiv, and hopefully when I go through, you will get some take-home points which help us to serve our people better. Most patients with type 2 diabetes do not achieve HbA1c goal. This is enhanced data. It may be quite old. You may tell it's a 20 years data, but you see that 30 or 40% of the people, our HbA1c target is less than 7%. If you do a country specific...
excuse me, sir. I don't think we can see your slides moving. Or is it just me who is seeing the same slide?
No, it is moving. My computer is moving.
Okay. Can the organizers confirm if it is, they can also see it moving?
We can see the CV slide now.
This is the most patients with the type 2 diabetes slide. Can you see this?
Yes, yes, sir.
Yeah, my computer is moving nicely.
What is on your screen right now, sir?
Most patients with the type 2 diabetes do not achieve HbA1c goal.
No.
It's not.
Okay, what I'm seeing is one rare positive thing about webinars. That slide is what I'm seeing.
So that is the last slide. Now I've got to this slide. What do I do now?
So can you just escape?
Please wait, sir. We'll check. We are checking on it.
I'll escape. Okay.
Yeah, just escape your slide and go to the first slide once.
Go to the slideshow.
You can close the slide first, sir.
Can you let sir share his own slides, because I think he is not controlling the slides at this point.
No, it is moving.
I think Jothydev sir has to close the slide if he is not sharing, so that you can shut down the PowerPoint and then you will share from here.
No, I have already shared.
Can you stop here, sir?
1 minute. Where am I now? I'll do the share screen and it is coming against share. So basically I've stopped already.
Yeah, now you can share, sir.
Now I can share. I need to open the slide again because I've closed after you have told. Okay, I have done the share screen. Can you see my first slide?
Yes.
Yes, sir. Yes.
You can go for the presentation view, full screen.
Yeah, I have done the presentation view.
Yeah.
And I'm taking a cursor. Where is the cursor? Presentation views.
Yeah, now it is presentation view. Yeah.
That's fine. Okay.
Yeah.
Now it's moving.
Yes, sir.
Okay. So most patients, even if 15 to 20 years old data, most patients are not reaching. And if you go to the country specific, if you start from the England, Wales, you see what is the percentage of the people are not achieving at all. That's a big number. About US, Europe, Canada, Latin America. And these are some of the data from our hospital, the Manipal Hospital, Bangalore. This is one of the, they're quite a bit old. In our OPD, I agree this is a tertiary care hospital, more complicated patients you see, there is no doubt about that. Hardly 40% of the people HbA1c less than 7%. We have done one hospital survey which showed 13% of people HbA1c less than 7. Another one showed average HbA1c of 2,244 people when people are admitted in the hospital are 9.1. So basically we are quite far off from our ideal targets. So the question comes that why people with type 2 diabetes do not reach their therapy goals. And the potential reason is clinical inertia, that elephant. I need to take this out. And that's the agenda I thought I'll talk. Therapeutic inertia, the barrier to comprehensive diabetes care. Choosing the therapy to achieve a composite glycemic outcome. I will explain what do I mean by composite outcome. And then I will tell you a pragmatic study on lead-up prime study quickly through how it can help whatever Dr. Rajiv tried to propose. Barrier to comprehensive care. Therapeutic inertia, how do I define? This is a therapeutic failure to achieve objectives within a reasonable period of time. Now, what is reasonable period of time? You can individualize depending on the person sitting in front of you. Or failure or delay in the treatment intensification among the patients who do not achieve the treatment goal. As a general practice, and we all know this type of slide is seen that prevalence of diabetes is increasing hugely both in men and women. And our standard WHO and IDF data tells that about the people died of diabetes, HIV, say 1 million. 0.7 million HIV, 1.2 million tuberculosis, 0.4 million malaria. So it's a big burden about the people atherosclerotic disease and uncontrolled diabetes. Causes, there are a lot of factors out there. A lack of knowledge or negative attitude of the evidence-based guideline, suboptimal doctor-patient communication, patient characteristic, and the problem of clinical and organization context. But the issue is very clear. We always used to think that I am Mr. Perfect, the person sitting in front of me and not following me. That's not right. Actually, studies have proven that the clinical or therapeutic inertia, 50% are because of healthcare professional. You and me need to take the responsibility. 30% for the patient, 20% for the healthcare system. If I can go one by one, I'm trying to move a bit fast because we started a bit late. That provider level, okay, we have a problem with the time, different demands. We don't want to implement particular guideline. We have a perception of side effect, but last three are very, very important and absolutely correct to the studies show. The fear of weight gain, fear of hypoglycemia, fear of injectable therapy, these are main concern to barrier to get a good glycemic control, which we all need to take the responsibility. But 30% is because of the patients. Some of them are too much kichi-kichi about the side effects. Before taking everything, they will take hundreds of things. They will take 100 of cola, Pepsi side effect, nothing will happen. Pani puri, no side effect there. But when I give a medicine for diabetes, doctor, are you sure this medicine doesn't give a side effect? And this is a part of a group of people. Misunderstanding of treatment regimen, multiple morbidity, you'll have to accept. The comorbidity is a big issue. Polypharmacy is a big issue. People are afraid of needle, acceptable. Nobody likes to inject. Who will like to inject? Unless you are, nobody wants to see a doctor, unless you are in desperate need. Injection-related anxiety, fear of self-monitoring, and pill burden if you are on multiple tablets. But the system level, we also need to do. Although my slide showed 20% is because of organizational defect, our health infrastructure, we need to improve. Forget about others, we need to talk about our country. The corona COVID-19 pandemic had showed very clearly we are crap. Our infrastructure of the health as a part of the nation is crap. We need to improve. We spend hardly 1% of our GDP on the health. This has to change. No point in blaming doctors, no point in blaming patients. And the population level benefit in terms of prevention and management diabetes are huge. Just we need to implement simple thing like a lifestyle modification. We are talking big about prevention diabetes, but we need to implement that from the beginning, probably from the school and the community level. We need to address the strategies so that our awareness improve, the health education improve. We are not talking about the qualification improvement. We agree there are limited availability, there are some cost of medicine is there, but I think one other good way we'll do that the digitization, the people's data in the database, that helps definitely to give for we all the time we get the data how much we are doing. That will make us move further in a better way. So what are the solutions now about therapeutic inertia? One, we can choose a pharmacotherapy which achieve most of the things that we want. See, diabetes is not only HbA1c control. Dr. Rajiv has clearly showed about pipes and pumps. We need to get through and comfortable with the clinical guidelines, whichever is practical, implementable, and possible and affordable in our setup. And we need to intensify and the treatment as early as possible. We used to tell about hit hard and hit early so that the control gets better. So let's come to this composite endpoint. The composite endpoint, important is that it's not only the HbA1c control we are talking. We have a lot of other things. We can't just have a single endpoint to see, well, this HbA1c, whether you are alive or dead, your heart has gone, brain and blood, doesn't matter, HbA1c 6.9, I'm very happy. This will not work. And we need to look on all the issues at minimum HbA1c, less hypo or no hypo, and no weight gain, or preferably weight loss, along with atherosclerotic cardiovascular improvement and renal benefit, cardio-renal benefit. So this will tell us about the composite endpoint. Now, you have seen this slide plenty of time. This is short-acting GLP-1, long-acting GLP-1, SGLT2 inhibitor, DPP-4, sulfonylurea, TZD, insulin, and you are taking the same points. Nothing extra we are talking. HbA1c, hypoglycemia, weight, cardiovascular effect, and what are the main important disadvantages. Every molecule has disadvantages, but see in this, how many reds are there, which we don't like, and how many greens are there, which we love it. And this is what a long-acting GLP-1 analog scores about all other molecules. Now, this we have seen about different pathogenetic mechanisms of diabetes. So we need to tackle each and every one, starting from pancreas to liver, to brain, to muscle, to kidney, to fatty tissue, intestine. And as you see, most of them are actually taken care of by GLP-1 receptor analog. And that's how the benefit is seen. We have a short-acting exenatide and lixisenatide we hardly use now. We have an intermediate-acting, probably liraglutide you should tell, and the longer-acting like dulaglutide, albiglutide will not get, semaglutide you hopefully will get, and this has not yet come yet. So if you see the glycemic control, the different RCT, the randomized control trials and the real-world evidence, the clinical development program from monotherapy to add-on therapy, metformin, sulfonylurea, thiazolidine, insulin, and so on, the deep blue one is liraglutide 1.8 milligram. That is the perfect dose if the patient tolerates. And see the HbA1c reduction is 1.5, 1.6 in that range. If you see the real-world studies from the HbA1c lowering, and some of them are actually quite a bit more or less, we can certainly tell they are above 1, probably approaching 1.5%, which is good. Then a comparative study with the different GLP-1 receptor analog, if you see that, the blue color again, 1.8 milligram of liraglutide scores quite high in the differential in comparison to the others, as is the number of people achieving the glycemic target. Here we are trying to see how many percentage of the people getting HbA1c, 7%. As you see, most of these countries are quite a big number. Some HbA1c less than 7%, that's a big target. And that's what we tell. When you compare it all the molecules, little older data, all the molecules here, 60% of the people which can achieve the HbA1c correctly, and if you see all three factors, HbA1c less than 7, no weight gain, no hyperglycemia, liraglutide 1.8 milligram is the best in comparison to all other molecules. Well, pleiotropic effect, Dr. Rajiv has clearly mentioned, that's exactly the same thing, total cholesterol, LDL, and triglyceride, liraglutide, systolic, diastolic, BP. I'm going to go quickly on this, and cardiovascular biomarker like PI1, BNP, and high sensitive CRP. and that's ultimately giving us an anti-atherosclerotic effect. That's what we learned from the last session. So if you see the ideal anti-diabetic drug to achieve a composite metabolic outcome, so for the glycemic efficacy concern, fasting sugar, PP sugar, and HbA1c. For the hypoglycemia less, weight gain less or weight loss, preservation beta cell function is a bit of conceptual thing, a cardiorenal benefit, and certainly this is the correct molecule to choose from. Now let us see from a pragmatic trial which has just been presented in the virtual ADA in last month, LIRA prime study, what it tells very quickly. So this is a pragmatic clinical trial. There is a difference between a randomized control trial and the pragmatic trial. The main difference, as you all will be knowing, that here the strict criteria of inclusion exclusion is very strict and you can hardly anything do. Not flexibility is very less. But in the pragmatic trial, we can recruit more people in a broad indication to get a better introspection about the molecule. So that's what we tell here, full spectrum of intervention in everyday clinical practice, whether it actually works in the real life situation or not. So what we have done here, type 2 diabetes more than 3 months, HbA1c 7.49, only on metformin, one arm continued on OAD, discretion on investigator. We have added alpha glucosidase, gliptin, meglitamide, SGLT inhibitor, ACU, TZD, whatever investigator wanted. And other arm on the metformin, we have started on liraglutide and up titrated 0.6, 1.2, 1.8. So this one is liraglutide on top of metformin. This is OAD on top of metformin. Okay. Now the primary objective is to see the glycemic efficacy. Okay. Now this is the different definition. Time to inadequate glycemic control as defined HbA1c more than 7 in 2 scheduled clinic visits, 2 visits consecutive in the first 26 weeks. All these are important. That's what the graph I'm going to show. In first 26 weeks, how many people did not achieve the glycemic control, that is less than 7%, in the 2 consecutive visits? And the secondary outcome and other things we are comparing to the other groups. The secondary endpoint, HbA1c, without weight gain, glycemic parameter, and the safety parameter, we obviously will be checking about hypoglycemia and adverse reaction which leads to discontinuation of the trial product. This is a multinational project and India did participate. We have nearly 10% of the 2,000 people who participated, who completed the LIRA prime trial. This is our baseline characteristics. Interesting to see, as I was telling, between pragmatic and RCT, very few RCT you will be seeing that females are more than 30%. Here nearly 50% of the female patient. Age is that our daily people around 57. Body weight, BMI is a bit overweight. Diabetes duration around 7 years. HbA1c average 8, and metformin. More than 900, nearly 900 people in each group has metformin, either 1.5 gram or more. And this is what we see in our practice actually. After metformin, what next? The drought between a gliptin and SGLT inhibitor and the LIRA prime trial, it was left on the investigator choice. So 48% people on SGLT inhibitor, 40% people on gliptin, and rest on the other. So this is just like in the OAD arm, metformin plus OAD arm are exactly like your and my clinical practice. And this is what we see, the result. The cumulative incidence plot time to inadequate glycemic control. So here, whichever curve is lower, that is better. So this is our liraglutide, the blue one, and the green interrupted and OAD. As you clearly see, from the 26 weeks onward, whenever we started the statistics, that liraglutide arm, just metformin liraglutide, did much better than the other arm, significantly lower glycemic control. If you see the difference between liraglutide and OAD arm, liraglutide reduced 0.3% HbA1c more, fasting blood glucose around 12 milligram, this is a millimole, body weight 0.6 kg more, and systolic diastolic BP did not change much, but there are a lot of statistical significance in all the parameters for the weight and fasting sugar and the HbA1c is concerned. And if you see now as a proportion, see the white one is the liraglutide and the green one is the OAD arm. So HbA1c target less than 6.5%, LIRA is better than OAD. HbA1c reduction less than 7% without weight gain, lira is better than OAD. HbA1c less than 7% without hypo, symptomatic hypo, lira is better than OAD. And if you see all 3 points, lira is better than OAD. So this pragmatic trial clearly showed just adding lira on top of metformin is much better than adding any other OHs on top of metformin. That's what exactly we could document in this. So in the conclusion, this study showed very clearly in a primary care environment when metformin is inadequate to keep a control of the patient with the type 2 diabetes, adding liraglutide compared to OAD, number one, patients spent significantly longer time with adequate glycemic control. Number two, there is superior glycemic control. Number three, more patient reaching HbA1c target. And the number four, about weight and hypoglycemic benefit. So that's the agenda I started, addressing the elephant in the room, therapeutic inertia, comprehensive management of diabetes. I think liraglutide has proven as a strong molecule to push the elephant out of the room or to push the therapeutic inertia out of the room. And in summary, this therapeutic inertia is a significant obstacle to reaching the glycemic target. All of us understand very well. Achieving composite glycemic outcome is the key for comprehensive diabetes management. And the GLP-1 receptor analog help patients achieve a composite glycemic endpoint. And newer routes of administration, that is the way forward. Now we have initially exenatide, then liraglutide, then dulaglutide, now semaglutide injection. Now we are going to get, and trials have been completed on semaglutide, oral semaglutide, that pioneer rate of series is already been licensed abroad, but India it has not been licensed. That will be wonderful to get the oral molecule of GLP-1 receptor analog. So at least the people who are afraid of the injection, they don't want like injectable, for them, it will be a wonderful molecule to reduce the therapeutic inertia. My sincere request, be safe. We are going through a very hard time. We follow common sense and we need to win this battle of COVID-19. History is in our favor. That used to happen in big kingdoms and in heaven also probably. That's Debraj Indra, and this is happening here. And as I believe WHO recently tells, it is actually everywhere. So we need to put the mask, and also we need to make the social distancing is very clear. I do understand the left of the slide, there is a social distancing is going on, but the right of my slide, I don't know what is this girl actually is doing, whether she is trying to keep a social distancing because she has a fight with boyfriend or husband or brother and so on. But let you and me practice social distancing, practice sanitization, and use the mask in everywhere to keep ourselves safe. Thank you very much for your attention.
Thank you, sir. Thank you for that great review, particularly on the therapeutic inertia topic. And I actually would like to congratulate the JPEF team for adding this topic, the therapeutic inertia topic, because I think that is probably diabetes being one of the most important public health issues. Despite all the new drugs and strategies that we have, the biggest burden I probably think is the therapeutic inertia is a reason that majority of the patients who need to benefit from what we know is not getting benefited. I'll move on to the panel discussion and bring up a couple of relevant points. I'll start with Bhattacharya sir himself, connecting the two aspects that he talked about, one about the therapeutic inertia and a second about the overwhelming evidence supporting GLP-1s, particularly in terms of reducing cardiovascular morbidity and mortality. So this is a health economics question connecting the two. So the question is, despite of such overwhelming evidence in favor of GLP-1s, how much do you think is the actual penetration of GLP-1s across the country? And how much do you think, and I honestly think that it is very low and probably has to do with the fact that it is quite an expensive drug, which probably only mostly the upper class patients can afford. I know that the health economist will make an argument saying that it is upfront cost to bear, and on the long term you will save up on preventing the complications. But the upfront cost, is it something our patients are able to bear, and how much is the cost a big therapeutic barrier as far as the penetration of GLP-1 analogs are concerned?
Yeah, that's what I tried to tell about the cause of therapeutic inertia. I think a state or government has to take the responsibility, not that everything the patient and the doctor will tell. See, that's the reason I told you that 1% of the GDP we spend for the health, and that's exactly what is happening now. Nowhere we are getting bed, nowhere the infrastructure is so poor. We need a lot of input. Just blaming the doctors and the healthcare workers and beating them, nothing will be achieved. I completely agree with you. If you consider the out-of-pocket cost, it is a costly medicine. Even if I am practicing in Bangalore, our clients are supposed to be a better socioeconomic status than national average. Then also, certainly it is a big point, no doubt about that. We doctors as a healthcare professional, we can't do anything. So it'll have to be done from the state. The state has to take the responsibility of our health. And most of the people with the diabetes, they will not die of diabetes. They will die of diabetes, atherosclerotic cardiovascular disease, renal disease, and the heart failure. And that's what we need to understand very clearly.
Thank you. Thank you, sir. I'll come back to, is Dr. Rajiv, sir, still with us?
Yes.
Yes, sir. Thank you, sir. A question to you. You had very nicely contrasted GLP-1s and SGLT2, particularly from a cardiovascular mortality standpoint. And I think you did allude to how to pick each one in circumstance. But for the benefit of the audience, in a simple way, how are you going to pick between these two, particularly when you're primarily looking at a cardiac patient, MI patient with diabetes? How will you make a decision, leaving the cost aside? How will you pick? When will you pick GLP-1 and when will you pick SGLT2?
That is something I think, let me say, is kind of carry-on message what Dr. Bhattacharya showed. If you have an expressed atherosclerosis and diabetes, there is no discussion which is the molecule. The molecule is GLP-1 receptor analog. And the good thing is, unlike SGLT2, you can use this molecule in the CCU bed. That is what I do. I do angioplasties. I tell them this is not a sugar injection, this is a heart injection. And that will save you from angioplasties because large number of my patients understand that they have to come back. So once you give them this impression that this is the injection who will keep them away from a cath lab, is very motivating to the family and particularly the wife. And once the other extreme is there is a patient who has got diabetes, atherosclerosis, and cardiac failure. Then they go probably one by one as you can go about. So my bias towards GLP-1 is probably it should be a molecule like a crash cart table molecule where every patient post-angioplasty, post-CABG should be given in hospital liraglutide. I do not know why it is not being done at our end, but it is done in my place in cardiology. And if you are dealing with cardiac failure because of LV dysfunction, probably SGLT2 will come first, and second choice will automatically come, the other molecule will become a second choice. I think I'm relatively clean, simple. And if you are complicated by low GFR, less than 30 kind of thing, GLP-1 comes. If you are higher than this, and albuminuria, probably SGLT2 will come. If you have an obese patient, weight reduction is more with GLP, so you will go for this. And most of our patients are obese. So I'll say in my coronary care unit, if I am dealing with atherosclerotic diabetic patient, I start post-angioplasty, post-CABG, post-procedure, acute MI, every patient on liraglutide.
Thank you, sir. Very key message for all the audiences. So much of choice at this point, and the risk profile of the patient. There are so many different variables to consider, as sir had just mentioned. So these days, you cannot blindly start an OHA or a drug. There are so many different risk profile to really study the patient in depth to figure out which one they will benefit from the most. I just have one more quick question. Is a very mechanistic question to again Agarwal sir. Contrasting the microvascular and the macrovascular complications, do we know what is the differential determinants of these two? Why do we have macro coming in earlier? And then why is it that the previous OHAs had some protective benefit to the microvascular but not macrovascular? And then the newer drugs currently have been shown to have a macrovascular benefit?
You see, you have to understand the basics of atherosclerosis. The microvascular is a capillary damage. It is not pronounced atherosclerosis. While macrovasculosis is atherosclerosis, there is a lipid hypothesis, there hyperinsulinemia. So there is a background which start, like I say, what I say, I mean, you will all agree with me, the diabetes in terms of vascular compartment starts at least 15 to 20 years before glycemia comes. Hyperinsulinemia, dyslipidemia, atherosclerosis, they start before in macrovascular compartment. And the moment glycemia comes, the microvascular compartment comes in. So my message is, the moment you get a patient of retinopathy or you get a patient of nephropathy, don't forget heart, because that is a killer disease. And that is what we have to pick up, that these patients should be subjected to treadmills, risk assessment, whether they are dealing with hidden atherosclerosis in macrovascular compartment. The problem with macrovascular is it kills. It does not abrogate, it kills. So apart from the glycemia part, because these drugs are vascular drugs, they are not hypoglycemic drug to that extent. So probably their effects is more on macrovascular compartment rather than microvascular, because
We are very honored to have with us Dr. John Panika, ENT Head and Neck Consultant, Trivandrum, and former President, Association of Otolaryngologists, India, Kerala, to chair our next session. Over to you, sir.
Good evening, all delegates, and thank you, Dr. Jothydev, Dr. Sushant Joshi, and all the team of the organizing team, and for giving me this privilege of chairing this session, very important session. Actually, I have been a thyroid surgeon for the last 40 years and was wondering why this relationship between thyroid and diabetes. A lot of thyroid patients I have seen with the diabetes. We know the type 1 diabetes and the thyroiditis both have an immunological basis. But what is the relationship between diabetes, type 2 diabetes and thyroid? So we nowadays see a lot of, possibly both are lifestyle diseases, but still we see a lot of cases, and I am sure today's speaker, Professor Mala Thermalingam, will definitely highlight on this particular issue. She is the Professor and Head of Department of Endocrinology in MS Ramaya Medical College, Bangalore, and also she is the Director of the Bangalore Endocrinology and Diabetic Research Center. So welcome, Dr. Mala, and over to you.
Thank you so much for the introduction, Dr. Panikar. Just give me 2 minutes to share my slides.
Yeah, sure.
Is my slides visible?
Okay.
Are my slides visible?
Yes, ma'am.
Yeah, thank you so much. So very good afternoon to everyone. And again, thank you very much for having invited me for this August meeting. And which is thyroid and diabetes. But I do believe that it's a very important topic, because just like Dr. Panikar has just now said, both of them are twin epidemics and causing a lot of morbidity and even mortality in our country. So basically, today we will look at my agenda, which is like, I'll talk just a slide on what is type 1 diabetes, because I think most of us do understand what is type 1 diabetes and its association with thyroid. But basically, to look at type 2 diabetes and hypothyroid, looking at prevalence of thyroid dysfunction and diabetes, what is the pathophysiological mechanism linking the two. Then I'll go on to talk about hyperthyroidism and type 2 diabetes, and the treatment link, the link between treating for diabetes, how does it affect thyroid, and treating for thyroid, how does it affect the diabetes, and I look at guidelines and then a few conclusions. So Basically, type 1 diabetes and hypothyroidism, this is very well known. We all know that we have to screen for hypothyroidism in all our type 1 diabetic patients. If they are not overtly hypothyroid, we should look at antibody titers and see what is the propensity that they're going to develop hypothyroidism. Both of them are autoimmune conditions, and when they occur together, they are part of the polyglandular autoimmune syndrome, APS3. We know that autoimmune thyroid disease presents in about 17 to 30% of type 1 diabetes patients, and Hashimoto's thyroiditis, like Professor was just telling, is associated with 10% of patients of type 1 diabetes, and approximately 1/4 of women with type 1 diabetes will develop postpartum thyroiditis. So the association is well known. It is also known that the thyroid gene, the TRH gene, is important in the formation of the pancreas also. So there are a lot of interactions and associations. But now let's look at hypothyroidism and type 2 diabetes. Now, we all know that diabetes is an epidemic situation, and in India, we have a huge number, almost 73 million diabetics in our country. And if you look at thyroid, we are not far behind. 42 million people in India have thyroid disorders. This was a paper that was published in The Lancet in 2014. It's a sort of a discussion where he talks about speaking to different experts in the field of endocrine in India, and he has put their thoughts. And in another paper, it has said that hypothyroidism is the most common of thyroid disorders in India, affecting 1 in 10, which is a huge number, roughly about 10%. And prevalence of hypothyroid in India is 11%, compared to only 2% in UK and 4.6% in the US. What has happened? There's a lot of speculation why hypothyroid is more. Some say it is the universal iodization. Some say it is the insulin resistance. And so we have a lot of mechanisms to understand that maybe thyroid is increasing actually in our community. The association of thyroid and diabetes was known almost 100 years back, first with hyperthyroidism, and then of course, hypothyroid came in. So this was a very elegant paper published by Talwarkar, who actually looked at what is the prevalence of hypothyroid in type 2 diabetes. So what they did is it was a cross-sectional observational study where they looked at type 2 diabetes patients, and they also looked at type 2 diabetes with hypertension and also looked at hypertension separately. Roughly about 500 in each of these groups. Then they went back and looked at how many of those patients of diabetes had hypothyroid, or how many of those with type 2 diabetes and hypertension had hypothyroid. A startling number, or in type 2 diabetes, the prevalence of hypothyroidism was 24.8%, and the prevalence in type 2 with hypertension was about 28.9%. This is not very different from global literature, which also quotes somewhere around 25 to 31% being the prevalence of hypothyroid in diabetic patients. Now, why does it happen? So let's look at the role of TSH. So TSH, which is the thyroid stimulating hormone, directly affects metabolic parameters and stimulates leptin secretion in adipose tissue. We know metabolism and leptin are closely related to diabetes. It stimulates hepatic glucose production, increases expression of G6P, that is glucose 6-phosphate, and phosphoenol pyruvate carboxykinase, and of course leptin, which is regulated by the TRH gene expression, which I told you about. Now, let's look at exactly what happens when I told that. So at the level, both in the central and peripheral, it has a role to play in glucose homeostasis. So if you look at the liver, then you see that there is increased gluconeogenesis, there's lipogenesis, decreased glycogen synthesis, and increased glucose output because of glucose 6-phosphate, phosphoenol carboxykinase, malic enzyme, retinol and binding protein, protein kinase beta, decreased glycogen synthesis, and at the peripheral tissue, there is increased glucose transport because of GLUT1 and 4, increased lipolysis because of beta-2 adrenoreceptors, increased glycolysis because of PGK and H. This actually is also related partly to MODY also. At the mitochondrial level, also it has a genetic basis where the PPAR gamma and coactivator 1 alpha is increased. So there is effect both peripherally and at the centrally, causing glucose homeostasis problem. As you can see when I was talking to you, there are some actually mechanisms which actually increase glucose, and there are some mechanisms which actually decrease glucose. So that is why if you look at hypothyroidism in the infant, it may actually cause hypoglycemia. One of the causes of hypoglycemia in a neonate is hypothyroidism. And on the other hand, because of insulin resistance and all the mechanisms we discussed, it can cause hyperthyroidism also. So what happens in a nutshell, to know what happens actually in the body, what I have discussed there is the GI tract, it increases glucose absorption. At the liver, it increases hepatic gluconeogenesis. At the adipose tissue, it increases lipolysis and increase free fatty acid, thereby increasing the insulin resistance. At the skeletal muscle, there is increased glucose uptake. Pancreatic beta cell is increased insulin secretion. And ironically, it also increases the glucagon secretion. So now, just one slide to look at how it can cause hypoglycemia, the hypothyroidism, because there is suboptimal disposal of glucose, suboptimal absorption, delayed gluconeogenesis, and less than adequate hepatic glucose output, and can cause hypoglycemia. So basically, just to understand that it can cause both hyperglycemia and hypoglycemia in hypothyroidism, and there are mechanisms. So now let's look at hypothyroidism and complications. There is well known that there is increased risk of nephropathy in type 2 diabetes, even with subclinical hypothyroidism. And this could be explained by decrease in cardiac output and increase in peripheral vascular resistance in hypothyroidism, resulting in renal blood flow and GFR. Treating this improves renal function. All endocrinologists have had such patients, and we know that we just need to wait, get it in order, and then see what happens to creatinine or the GFR. Most of the time it improves and comes back to normal. Diabetic patients with subclinical hypothyroidism have more severe retinopathy than euthyroid patients with diabetes. And if you're not managing well, the patient can go into hypoglycemic events also if the thyroid is not well treated in a patient with diabetes. So now let's particularly look at the CVD risk. We all know that the TSH can cause high cholesterol levels, and in those who have high cholesterol levels, it's imperative that one should look for thyroid status to see whether the dyslipidemia is mainly due to hypothyroidism. So this may magnify CVD risk through dyslipidemia, and we know hypothyroidism causes hypertension, mainly diastolic hypertension. Several studies have reported interdependent association between thyroid status, dyslipidemia, and insulin resistance. In euthyroid patients, even if they are low normal thyroid hormone, it can be present with dyslipidemia and insulin resistance. And this is one of the reasons why even a subclinical hypothyroidism needs to be treated. Once again, subclinical hypothyroidism is a controversial topic and a discussion on by itself. But one reason why we need to treat even if there is subclinical hypothyroidism, if there is dyslipidemia. So in subclinical hypothyroidism, very elegant paper by Biondi, who has showed that it was present in 5 to 8.6% of diabetes, and greater prevalence of nephropathy, cardiovascular events, and low normal FT4 were significantly associated with increased insulin resistance also. So one slide on hyperthyroid and diabetes, the mechanism. So if you have hyperthyroidism, you have glucose catabolic pathway, glucose transport by facilitated diffusion, lipid catabolic, both by lipolysis and glucose metabolic pathway. There is more lactate formation, more free fatty acid, more glucose output at the liver, and hyperglycemia. I think this concept is not very difficult to understand because very simply it's a counter-regulatory hormone, and we know that thyroid hormone is increased even in hypoglycemia. So we know that increases blood glucose. So there are some associations which are very interesting. I thought I will talk to you about it. About ghrelin. If you look at ghrelin in people who are treated with, who are not treated with hyperthyroidism, it's quite low compared to the treated and the control group. And if you look at even, and it corroborated very well with hyperinsulinemia with and insulin resistance. So association of insulin resistance has also been found. Elevated glucose turnover increased, intestinal glucose absorption, elevated outputs, increased free fatty acids, increased both fasting and the postprandial insulin is increased, and there is increased peripheral glucose transport also. Now, the interesting thing is the thyroid, hyperthyroidism, if not treated adequately, will end up in thyroid storm, and this can cause diabetic ketoacidosis, and diabetic ketoacidosis in a patient with hyperthyroidism, if not treated well, can end up in thyroid storm. So both at the liver, there is hepatic glucose output increase, in the muscle there is decreased glucose use, increase of proinsulin at the pancreas, and the kidney has increased insulin clearance. This is causing hyperglycemia, insulinopenia, diabetic ketoacidosis, and resulting in thyroid storm. So it is important to understand this so we treat them correctly to prevent these problems. And this again is a similar thing that it can sometimes even cause hypoglycemia because of reduced insulin synthesis. So both hypo and hyperthyroidism can cause both hyper and hypoglycemia, which everyone should remember. The last section of my talk is on treatment and interactions. Very interesting. What does each one of our drugs that we routinely use cause to the thyroid? Like we use metformin, what does that do? It reduces TSH level. It reduces also risk of thyroid cancers, reduces thyroid volume and nodule size. Sulfonylureas, on the other hand, increase the risk of thyroid cancers and increase risk of hypothyroidism and goiter. Very mild, but studies have shown that it does. But however, glitazones inhibit the activity of thyroid hormone receptors, increases TSH, increases IGF-1, decreases FT4, and aggravates thyroid-associated orbitopathy for the simple reason of water absorption. Now let's look at the drugs which are used for thyroid, hyperthyroidism or hypothyroidism, and see what happens to the diabetes. So methimazole is related to development of insulin autoimmune syndrome, may cause hypoglycemia in patients with diabetes. Carbimazole causes insulin autoimmune syndrome, and levothyroxine causes, when you're treating, because it reduces the insulin resistance, can cause reduced fasting and postprandial glucose levels and reduce the HbA1c. A very elegant paper has also shown this. This is the HbA1c in hypothyroidism and hyperthyroidism. You can see the hypothyroidism, the HbA1c is really high, even compared to hyperthyroidism because of the insulin resistance. But on treatment, just look at, this is hyperthyroidism. Post-treatment, it has done nothing much. The HbA1c stays almost the same. But look at hypothyroidism. When you have treated, the HbA1c has significantly reduced irrespective of the treatment for diabetes. So treating hypothyroidism well and correctly is very important to reduce the HbA1c and keep the sugars in control, not causing hyperglycemia or hypoglycemia. So what are the guideline recommendations? Very quickly, this is the Indian consensus. Patients with diabetes require more frequent screening for thyroid disorders compared to general population. Type 1 should have a check at diagnosis and then again every year. Type 2 diabetes should have routine checkup for thyroid though every year is not required, first at their diagnosis and then whenever they become symptomatic, just for the cost. And then international guidelines, the ATA says that patients with diabetes require more frequent testing, TSH from 35 in every 5 years, and high-risk patients may be done more. What does the American Association of Clinical Endocrinologists say? You palpate the thyroid, and if you find it is there, then you do it at regular intervals. However, they don't have any specific recommendation for type 2 diabetes. And the British Association says you should do it at baseline, and routine annually is not recommended. And TSH and antibodies are recommended in diabetic patients in pregnancy and postpartum. So this was the recommendations of the international societies. So take home messages: autoimmune thyroid dysfunction occurs in 17 to 30% of adults with type 1 diabetes, and almost 30 to 40% in type 2 diabetes. Subclinical hypothyroidism is also associated with increased risk of diabetic microvascular complication, and thyroxine treatment may normalize fasting hyperinsulinemia and significantly improve insulin sensitivity in patients with overt and subclinical hypothyroidism and insulin resistance. Thank you very much for a patient hearing. And if there are any questions, I would like to.
Thank you, Professor Mala. Actually, that was a very, very comprehensive and very informative. And actually, I have one question. What will be the ideal TSH value we are expecting in diabetic patients?
The TSH should always be mid-normal most of the time. So if you're
there is no difference
it
whether
around,
it is diabetic or if the patient is associated, it will be.
Yeah, patient is on metformin, you may actually find a lower TSH. So if your patient is on metformin and your TSH is 4, you may actually be under treating him actually.
Okay.
Yeah, you would keep it mid-normal.
Oh, actually, in diabetes, we say that low carbohydrate diet is definitely has a effect. Actually, thyroxine also has some role in the glucose metabolism. So for such patients, even without diabetes, can we suggest a low carbohydrate diet for thyroid patients? Any relationship?
Yeah. May not be necessary, because once we start treating and make the euthyroid and make the metabolism absolutely normal. They don't.
So they can have the normal. Okay, fine. So that was a wonderful talk in the shortest time possible. 15 minutes is a very, very short time. Thank you very much. And handing over to the organizing team. Thank you.
Thank you, Dr. Mala Dharmalingam, for giving your valuable insights on the topic. And also thank you, Dr. John Panikar, for chairing the session.
Yes.
Thank you.
Thank you.
Now, we shall move on to the next session. Please join us in welcoming Dr. Benny PV, Professor and Head Community Medicine, Sri Gokulam Medical College, and Editor, Indian Medical Association, Kerala Medical Journal. Welcome, Benny PV, sir.
Hello. 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 Can you hear me? Can you hear me?
Yeah.
Yes, sir. Yes.
Okay. Next it. Hello.
Yes, sir. We can hear you. You may proceed, sir.
Yeah. Actually. Next topic is cardiovascular safety of sulfonylurea. Actually, today is the world of new anti-diabetic drugs. A lot of safer and safer anti-diabetic drugs for the cardiac protective, even cardiac protective anti-diabetic drugs are coming up. The older drugs like sulfonylurea came with newer modern version, like that is modern sulfonylureas are more protective in terms of hypoglycemia inducing power, and also the lot of people globally are using sulfonylurea nowadays. Even the sulfonylurea is very important for the developing countries like us, and also many African countries are socio-economically bad countries are now still using sulfonylurea in a large scale. Today, the cardioprotective effect, especially the diabetes is concerned with a lot of cardiac issues, especially the cardiac failure and all. So when we are using an anti-diabetic drug, the cardioprotective effect is always in question. So today the topic is presented by Dr. Tejas Shah. He is a very eminent in the field of diabetology. He is the diabetologist and the director of IVA Diabetic Care Center, Mumbai. He is honorary diabetologist, Cell Rahija Fortis Hospital, Diabetes Care Center, Malad and Andheri, visiting teaching faculty for fellowship in diabetology, and founder and treasurer of United Diabetes Forum and organizer of scientific committee and faculty of CID 2014, 15, 16, 17, 18, and 19. the faculty to teach CPS diabetology students, and also he's a very good practicing diabetologist for the last 20 years. I welcome you for the presentation on the sulfonylurea issues regarding cardiac protection. Thank you.
Thank you. Thank you, Dr. Benny, very, very much. Can you? Is it visible?
Yes, sir. Yes, sir.
And the slides are changing if I change?
Yes, sir. Perfect.
Yes, change.
Thank you, Dr. Benny, very much. First of all, a big thank you to Dr. Jothydev and the entire team for inviting me and giving me this opportunity for this webinar. And definitely, I'm missing the beautiful Trivandrum this year, but that's the situation is for all of us, and hope for the best for the next few months. Yes, so my talk is going to be, as Dr. Benny has introduced, is going to be related to cardiovascular safety of sulfonylureas. For a number of years, since the time the sulfonylureas were introduced in the 1950s, they have been a mainstay in per se in the management of type 2 diabetes. They have been the primary drugs that we've been using all over the world as a first line and second line therapies, no doubt about that. However, with the advent of newer drugs, with the advent of new drugs that we have in the last few years, the question related to its safety, its durability, its hypoglycemic effects, its weight gain, and its cardiovascular safety have all been keep coming. The questions keep coming to us one by one, and though a poor sulfonylurea has to prove them once again, time and again. So the entire controversy related to the cardiovascular safety of sulfonylurea started way back in the 1960s with the UGDP study. If you know, the UGDP study was the United Group Diabetes Program study that was initiated in the 1960s. It was primarily a study which was looking at the efficacy aspect of the various drugs available at that time, the tolbutamides, the metformin, and the insulin that was available. Where it was compared to placebo, the fixed dose insulin, variable insulin, and tolbutamide. And during the study, surprisingly, an excess risk of cardiac death was found in the tolbutamide group, almost 12.7%, as compared to 4.7% with placebo, and 6.2 and 5.9 was the percentage found within the insulin group. And this really created or rang the alarm bells, and the tolbutamide arm was stopped, and the experts concluded that the SU as a class were responsible for this increased association of cardiovascular mortality. And over a period of time, what has happened is that the alarm bells haven't just stopped ringing. Time and again, this question keeps rising related to the CV safety of different sulfonylureas. Though after a few months of UGDP, the questions were raised regarding the conclusions that came out in the UGDP trial and the way the trial was conducted. Subsequently, what we know is that we have now classified sulfonylureas into older and newer generation ones. The older ones are primarily the tolbutamide and chlorpropamide, which we no longer use. The second generation in terms of hierarchy are the glibenclamide and glipizide. And the newer ones are the glimepiride and glyclazide, which are supposed to be more safer. Now, following 2008, we know that FDA has made it mandatory for all new drugs to undergo a cardiovascular safety trial, where a drug is compared to a placebo in patients with a high risk of cardiovascular disease. Sulfonylureas per se are the older drugs that did not have to undergo a cardiovascular safety trial at that time. But what the FDA says that for a therapy to demonstrate that it is cardiovascular safe, it should show that it does not result in an unacceptable increase per se in cardiovascular mortality, in myocardial infarction and stroke, in hospitalization for heart or acute coronary syndrome, and other endpoints it looks at. So the question is whether all sulfonylureas are CV unsafe or is there a difference in terms of risk for different sulfonylureas? So let us see one by one what the evidence has to say for at present. If you look at the first aspect of cardiovascular mortality, let us look at some of the important studies and trials which have proved which sulfonylureas related to this cardiovascular mortality. This was one of the systemic meta-analysis which was done primarily. It was done mainly to look at the mortality risk and adverse CV events rates among patients using sulfonylureas. What it did was it looked at various trials which had sulfonylurea as one of the drug and which assessed the risk of all-cause mortality and CV mortality and look an incidence for myocardial infarction. 28 studies with more than 1,67,000 patients were included in the main analysis here, and the relative risk of death was compared to glibenclamide, where glibenclamide was put as 1. When we looked at the relative risk of death, the incidences for hazard ratio for glipizide and glyclazide, for glimepiride and glyclazide were much lesser as compared to glibenclamide. It was 0.60 for glyclazide and 0.79 for glimepiride. The incidences for glipizide was found to be similar to glibenclamide at 1, and the incidences for the infarction were higher for chlorpropamide and tolbutamide for mortality, higher than glibenclamide. So which proved that per se, like the newer SUs, the glyclazide and glimepiride were associated with a lower risk of all-cause and cardiovascular mortality as compared to glibenclamide. This was another study which looked at association between intensification of metformin treatment with insulin versus sulfonylureas and looking at the cardiovascular events and all-cause mortality that happened in these subset of patients. 1,78,000 metformin monotherapy patients were enrolled here. 2,948 were added insulin and 39,900 were added a sulfonylurea. A propensity matching was done in the study, which yielded ultimately almost 2,400 metformin plus insulin patients and correspondingly 12,000 approximately metformin per sulfonylurea patients. What it looked at was at cardiovascular events mainly, looking at cardiovascular mortality as a primary factor, and it also looked at fatal and non-fatal cardiovascular events. The events related to cardiovascular death and disease were higher in the metformin and the insulin group as compared to metformin and the sulfonylurea group, and that went on throughout the study per se over a period of 4 years. The event rate for fatal and non-fatal cardiovascular events were more or less similar in both the groups, which here again showed that sulfonylureas were CV safe when it comes to diabetes treatment and did not increase the cardiovascular death per se. If you look at the various cardiovascular safety trials that have been done like TECOS, SAVER-TIMI, and EXAMINE, all these studies, if you see, they had patients primarily which had patients had a high cardiovascular disease. They were compared to placebo. TECOS, where sitagliptin is compared to placebo. SAVER-TIMI, where saxagliptin was compared to placebo, and EXAMINE with alogliptin. The primary, the placebo group as well as the primary study group had almost 45 to 47% of the patients having sulfonylurea as one of the drug, and they were continued on that. And in both the groups, whether you look at the primary event group or the placebo group or the study group, the incidences of cardiovascular events did not go up in either of the groups per se, or in placebo group also did not show further worse CV outcomes, thereby again showed more or less safety with the sulfonylurea aspect here. Now coming to myocardial infarction and stroke, well, another controversy that all SUs have is because of the ischemic preconditioning effect that SUs abolishes. Yes, the older SUs like glibenclamide did have this problem. They bind to they have their action primarily binding to the sodium potassium ATPase channel, and which also has an effect on the cardiac myocytes, because of which there is a loss of the ischemic preconditioning which takes place. We know that with glibenclamide, and it has been proved. And because of this ischemic preconditioning effect being lost, the protective effect that it has on preventing the increasing the infarct size is lost per se. However, the newer sulfonylureas like glimepiride and glycoside, we know do not have this problem of abolishing this ischemic preconditioning because they do not interact with the myocytes on the heart. They are more selective per se in respect to SUR and SUR2. So when you look at some of the data related to myocardial infarction, this was one of the study done by late Dr. Sadikot. 76 type 2 diabetic patients here who developed coronary artery disease were compared with 152 controls. mainly looking at the risk of myocardial infarction, looking at risk of coronary artery disease, depending on the treatment that they were initially subjected to. So the hazards of developing coronary artery disease was associated with an initial treatment increase almost 2.4 folds with glibenclamide and 2.9 folds, almost 2 folds with glipizide. While if you compare when they looked at the hazard ratio with newer drugs like limipiride and glyclazide, it was almost 0.3 to 0.4 only. Again, showed here that initiating treatment with older SUs was associated with a higher risk of CAD, while the newer SUs was found to be much safer here. This is another study which looks at the risk and short-term prognosis of myocardial infarctions among users of anti-diabetic drugs. 6,000 patients, 6,000 odd patients detected who had an episode of myocardial infarction were compared with 67,000 almost matched controls. They looked at odds ratio for myocardial infarction. They looked at the case fatality ratio within a month of discharge also for patients who were on sulfonylureas. And what they found out was that the risk was much higher among older users, patients who are on older SUs. The odds ratio was almost 2.07, while lesser for patients with newer SUs here. When you look at the acute coronary syndromes again, the hospitalization data, this is important study which looks at the impact of the type of pre-admission sulfonylurea on the mortality and cardiovascular outcome in patients with acute myocardial infarctions. It looked at 1,300 patients with an acute myocardial infarction mainly, and they found out that the mortality was lower in patients who were treated with SUs, and when they compared it with other drugs, mainly with other OHs, the ratio was higher, 6.4, and with insulin it was still higher of 9.4%. So, and amongst SU treated patients, again, the in-hospital mortality was much lower in those patients who are on newer SUs like glyclazide and limipiride. They also looked at some arrhythmias and ischemic complications, which were found to be lesser in the newer SU group. On further analysis, when they compared the newer SUs like glyclazide and limipiride with glibenclamide, and they looked at death, they looked at arrhythmias, and they looked at any other complications, the event rate was almost 3 times higher in the glibenclamide group as compared to the glyclazide and limipiride group. They also did a propensity matching based on factors like prior history of MI or smoking or lipid levels. And again, in that, the propensity score clearly showed the 3 times lesser incidence of almost for death in the glyclazide limipiride group as compared to glibenclamide. Further sub-analysis was done in that study when they looked at whether the patients were on metformin or no metformin, insulin or no insulin, or prior MI or no prior MI, and age less than 65 or more than 65. And all the factors favored glyclazide limipiride in the study, and they did not show an increased incidence in the SU group at all. So clearly telling us that patients on newer SUs have fewer and lesser complications and lesser risk of mortality than those on glibenclamide. And all SUs per se do not have the same impact on cardiac outcomes and therefore should not be considered as a single pharmacologic entity. There have been some data related to glimepiride and glyclazide also. We know that glimepiride was used in the VADT arm, in the VADT study, which looked at the, and where the intensive arm, where we looked at controlling the blood sugars much stricter. And there was almost a 17% relative risk reduction in the CV events. An effect on microvascular was not studied here. When they looked at the advanced study also where glyclazide was used, again, the intensive arm had an A1C of 6.5, and there was also a 10% relative risk reduction in the combined micro and macrovascular events, but there was not an increased rate of events per se where the molecule glyclazide was used. The biggest kick that we can say that glimepiride or any SU has got now is recently with the result of the Carolina trial, which came up last year. Carolina, as you know, is the cardiovascular outcome study of linagliptin versus glimepiride. It's the first time a SU was studied in comparison to a DPP-4 inhibitor. It's a multinational randomized double-blind control study which involved more than 6,000 patients and 43 countries, and had patients with early type 2 diabetes with a mean duration of 6.2 years. It looked at primary outcome was a 3-point MACE, mainly CV death, non-fatal infarction, and non-fatal stroke. It also looked at secondary outcome, mainly of time of first occurrence of any CV event and the 4-point MACE, and number of patients with an A1C of less than 7 and proportion of patients with A1C less than 7 without significant hypoglycemia or weight gain. Most of the patients here, there were 16% of the patients from Asia and 300 Indian patients also out of the 6,400. And most of the patients were at an increased CV risk, with 35% having an established CV risk and 37 had CV risk factors. What it showed was that per se, the glimepiride was found to be not inferior to linagliptin, and or linagliptin was not found to be inferior to glimepiride. There was not it did not find an increased incidence of CV event, demonstrated CV safety per se between for both of the drugs. For the 3-point MACE mainly, the hazard ratio was 0.98, which was found to be non-inferiority. The time to occurrence of 4-point MACE was also found to be similar between the glimepiride and linagliptin arm, and therefore proving that it is CV safe. The risk of CV mortality or overall mortality was also not difference between the two groups. For all-cause mortality, non-CV mortality, and CV mortality, the hazard ratio is almost 0.9 and 0.82. What it also additionally showed was in terms of the durability. We are always questioning the durability of an SU, but here in the study, glimepiride was found to be equally durable in terms of HbA1c reduction like linagliptin over the entire period of 6 years of the study. So Carolina evaluated the long-term CV safety of linagliptin versus glimepiride, and it showed that it is per se safe, and it can be, and per se those cobwebs regarding the CV safety of SUs has now, I think, gone away. This was one of the chart that ADA 2018 showed pertaining to all the drugs that we use in terms of efficacy, hypoglycemia, weight change, CV effects, or any black box warning. If you see the modern SUs, they have been highlighted as high in efficacy. They are neutral in terms of CV effect. They are low cost and per se neutral in terms of renal effects. The safest consensus that was done in Southeast Asia also have endorsed modern SUs like glimepiride and glyclazide. They are backed by large body of evidences. Person-centered care, careful choice of SU is what is now required. Appropriate dosing, timing of administration, adequate patient counseling should be given, but patients should not be deprived of the advantage of this well-established drugs. In a country like ours, as we know that where patient financial constraint becomes one of the major factors for which patients do not continue treatment. And in the study, it has shown that 32% of the patients had said that it is one of the causes for not adhering to treatment. I think a drug like sulfonylurea, which has proved its safety and efficacy and CV safety, which is cheaper to the patient, I think goes a long way. If you look at the ADA ESD consensus statement also, for the first time in so many years, it has put cost as one of the options to choose a therapy, and it has endorsed SU or diazolidinedione as one of the choice after metformin if the patient cannot afford the newer drugs. So if asked what is more fearful of a disease than the disease itself, I think the answer should be the cost of the treatment also, especially for a country like ours where a patient is paying from our pocket for medicines. I think sulfonylureas with its proven CV safety has still a long way to go and a major role to play in the management of type 2 diabetes. Newer SUs are associated with a lower risk of all-cause mortality and cardiovascular mortality that has been shown. Newer SUs like glimepiride and glyclazide should be preferred or can be preferred over the older drugs which we have been using. And comparative effectiveness cardiovascular safety studies would still be required to determine the CV link. But at present, I think the case rests there that they are CV safe. Thank you.
Thank you, Dr. Tejasha. Actually, the role of sulfonylurea in cardioprotective effect is a greater relief for developing countries like us, because most of our government program is linked with metformin and glimepiride for the management of diabetes.
Right.
I think this will be a great relief for our country like us. So, any questions or anything like any?
So the discussion will be after the next two sessions. So now we'll move on to the next session. Let me call on Dr. Sandeeba, dental surgeon at Anandaburi Dental Care, to chair over the next session. Over to you, Dr. Sandeeba.
Thank you. Am I audible? Hello? Am I audible?
Yes, yes, sir.
Yes, okay. Thank you. Thank you, Jothydev sir, as well as the JPEF team for having me here to chair the session. The session is on diabetic eye disease screening in a diabetic clinic during COVID pandemic. It's a very relevant topic in the current scenario. To present on it, I invite Dr. Devin Prabhakar, who is a consultant ophthalmologist, Divya Prabha Eye Hospital, Trivandrum. He is a visiting consultant, Maldives and Government of Seychelles, traveling fellow in glaucoma, Royal Victoria Infirmary, UK, a cataract fellowship in Shankara Nethralaya, Chennai, Best Doctor Awardee, Government of Kerala, State Vice President, QP MPA Kerala, State Coordinator of Prevention of Blindness Project, member Kerala Clinical Establishment Act and Rules Making Committee, and a PADI certified scuba diver. Devin sir, the stage is all yours. Hello. Hello. Hello.
And also, of course, the upper part is really interesting. It should be below 6 hours of maybe not even ready. And the
Hello, Dr. David.
Devin sir.
Thank you very much. It's always a pleasure to be part of the Jothydev Diabetic Center program. And as always, we have a lot of innovations coming on.
So you're not visible?
I'm not able to change my slide. How can I share my still relevant topic like Dr. Sandeep said?
Now you're visible, sir.
Right. When you look at it, almost 63% of people know that they have a chance of developing eye problems or general problems, but around 10% are not really concerned. But among the problems, almost 50% are worried about the diabetic retinopathy or chance of going blind. Now, when you look, what got eye diseases, and 25% of and the chances of developing cataract and glaucoma are public, and cataract can develop. Stock is very important, and the importance of then the chance of developing blindness, the chance of going having blurred vision, the chance of needing laser surgeries have come down by almost 56%. And with early detection, almost 90% of vision loss can be prevented. And this is common throughout. When you look at the causes of blindness, almost 80% of people are blind because the 80% of blindness can be prevented or treated. So it's very important that everybody is aware about the potential blinding side of diabetes. Now, when you look at diabetes and the eye, it can cause a variety of problems, including cataract, elevated eye pressure like glaucoma. It can even cause small things like sty. And sometimes people are first aware about glaucoma, about diabetes, when they notice a fluctuating vision. Fluctuating vision happens when the sugar goes up very much or it comes down very much because of the osmotic imbalance in the eye lens. The power can fluctuate. So that can be an early sign of diabetes also. Now, almost 20% of people have got diabetic retinopathy at the time of diagnosis. And in 10 years, almost 50% of people would have diabetic retinopathy. And in 20 years, 90% of people have diabetic retinopathy. Unfortunately, for many of us, people come to us almost after 5 or 10 years into diabetes when they have got 50%, 60% chance of diabetic retinopathy, and treatment becomes very difficult. Now, when we look at the eye, this is the fundus picture that we see. Patient. Most of us would be aware about the exudates, the hemorrhages and all. Now, when it is as severe as is shown in this slide, when you have got a lot of yellow deposits all around, that's called hard exudates, then we have it is very easy for us to diagnose. Or if you have got a lot of red in the eye, like blood vessels, this is a picture of a neovascular vessels on the disc. Even this is very easy to identify. And this is also easy to identify. This shows extensive proliferation. But the issue comes when you have got very subtle changes like an early microaneurysm, which even ophthalmologists have got difficulty to diagnose. So that is why we say that all diabetic patients need to be seen by an ophthalmologist. Now, when you look at this slide, we see how a physician usually looks at the retina. Now, this is the direct ophthalmoscope. This has got two difficult problems. The first is that the area of visualization is very small. They can just only see the disc. So if there is a widespread problem without the perception, it is very difficult to diagnose something. The second is that the magnification is also very less. So it is very difficult to pick out microaneurysms and things like that. Now, the biggest problem now with the direct ophthalmoscope is, as you can see from this picture, you need to go very close to the patient to have a look at the fundus. Now, in this time of Corona, when the time of COVID, the chance of the patient getting a COVID infection from you or you developing a COVID from the patient is very high. In fact, the doctor who found out COVID, the coronavirus, is Dr. Li from China, who was an ophthalmologist. And unfortunately, he died from the coronavirus itself. So using a direct ophthalmoscope is a very foolhardy thing at this time. And I don't think any physician should be using a direct ophthalmoscope now. Now, when you a patient to an ophthalmologist, this is what we use, goes to the patient. We also have a breath shield that protects us from the patient's breath. Or we use yeah, now what we have is called the, can you hear me please? Hello?
Screen is not open.
Yeah. So now I'll go. Yeah, I'll go fast. Hello?
Yes, sir.
Sir, I think you have a network problem.
Hello?
Please try switching off your video and just keep audio.
Can you shall I stop my video then?
Hello, sir.
Yeah. Is it still, are you still able to see?
Sir, slides are visible, but you have to put in a PowerPoint, means the full screen.
I think we have lost him. Hello, organizers.
Yeah, sir. Shall we move on to next session? Because
Yeah, we will finish that session and come back to the session.
okay, okay. Then we will move on to the next session. We formally welcome Dr. Asha Ashik, consultant diabetologist, Jothydev Diabetes Center, Kochi, to chair the next session.
Thank you. Am I audible?
Yes, ma'am.
Okay. First of all, I would like to thank Jothydev sir and JPEF for giving me this opportunity to chair this important session. The session is on intermittent fasting after the keto diets. Excuse me? Am I audible?
Yeah, you are audible.
Okay, okay. So, after the keto diets and alternate day fasting, now intermittent fasting is gaining popularity. In fact, I am also a fan of intermittent fasting. I have also tried it and found it pretty easy to do. We don't feel that we are fasting when we do intermittent fasting. But is it good for a diabetic to do intermittent fasting? Or is it safe for a diabetic to do intermittent fasting? So intermittent fasting, can it be used as a tool for management of type 2 diabetes? That is the next topic. And to speak on it, we have a very eminent speaker, Dr. Arvind Gupta from Jaipur. Dr. Arvind Gupta, he has got fellowship of Madras Science Foundation, fellowship of Diabetes India, fellowship of RSSTI, FRCP Glasgow and Edinburgh. He has won several medals. He has been organizing secretary 31st annual conference of RSSTI and many other events. He is a member project review committee ICMR. He is visiting clinician Mayo Clinic Rochester, USA. He is associate editor of International Journal of Diabetes in Developing Countries. He has presented papers in various international conferences and has over 75 research papers published in national and international journals. He has contributed several chapters in postgraduate medicine, API Medicine Update, and is a member of ACE, API, IMA, RSSTI, Diabetes Association of India, etc. Over to you, sir.
Thank you, Dr. Asha. Shall I share my screen? My slides are visible.
Yes, sir.
Okay. And okay, so thank you very much, Dr. Asha. You are very much right regarding the opening topic. But let me first thank Dr. Jothydev, Gopika, and all the scientific team for this wonderful virtual JPEF conference, which I used to attend every year. Unfortunately, because of the corona infections, this year it is a virtual conference, but I congratulate for the wonderful scientific program. Dr. Asha, you are right regarding the whether it is safe intermittent fasting in diabetes or not, and that's why this is for the first time, as far as best of my knowledge, this topic is being discussed at any platform in the world. So this is for the first time I am giving you a new concept of having intermittent fasting and whether it is useful or beneficial in diabetes. If you would have said earlier, I mean 2, 3 years or 5 years back, that a person is advised intermittent fasting in diabetes, one will laugh on it, definitely, because we request or we advise our patients to have a frequent meals rather than the fasting in diabetes. Rather, in some cases, right, in Ramadan and other religious fasting, we used to actually ask our patient if they are in serious condition, acute conditions, please don't do any fasting. So let me start my topic as intermittent fasting in diabetes, and let me start my views and the some of the newer concepts which is generated in Canada and other places in the world. This is my disclosures, but nothing potential conflict of interest regarding this presentation. What I'll be doing, first of all, I'll give you the concept of intermittent fasting or fasting and then metabolic health, then how it is relevant in diabetes, and then I'll do the conclusions. So what is intermittent fasting? It is a period of voluntary abstinence from food and drink. That is the simple definition of intermittent fasting. And it is basically an eating pattern that cycles between the fasting and the eating. But it does not specify which foods you should eat and rather when you should not eat them. So that is the different kind of fasting. Let me start my views on this, sorry. Yeah. So this does not specify any foods or something which you can eat or which you cannot eat during the fasting. Different types of fasting regimes are there in the world. One very important regime is the complete alternate day fasting. In that case, one day you don't eat most of the time, and next day you are eating normal. Anything modified fasting regimes like you fast 20 to 25% of your food in that day, particular that day. Another is the time restricted feeding, means these protocols allow individuals to consume ad libitum energy intake within specific windows. So with some period of time, you can take whatever you like, and then few hours you don't take. Some religious fasting are also there. We have already have so many religious fasting in our country. Then Ramadan fasting, we know that it is from dawn to dusk, don't take anything, and then in the night time they are free to take anything. Then other religious fasts are also there, and we know that our ancestors used to do this type of one day in a week or something, these type of fastings they used to do. These are the three basic intermittent fasting which has been used in the world in the scientific studies. One is that it is the alternate day fasting, means on one day you are taking normal food, another day you are total fasting, then another, so alternate day you are having fasting. Another alternative is the 5:2 diet, means one day you are eating normally, second day you reduce your calories to 500 in the women and 600 calories in the men, and then next 2 days again normal, and then the fifth day again you have a calorie restriction. So this type of 2 days in a week you are actually doing the energy restriction or calorie restriction. Another is the 16-8 methods. What does it mean? That you are actually fasting from midnight to 8 a.m. No food. And then from 12 to 4 p.m. you take 2 meals. And then from 4 p.m. to midnight again you are fasting. So most of the time during only 4 hours in a day, whole week, you are actually doing taking your meals, and that meals is up to you how much energy you are taking during this 4 hours, and rest of the time you are not taking any food. So this is type of different types of intermittent fastings. So how does this intermittent fasting affects your metabolic health? It is well known in the humans that a single fasting interval, just a single overnight fasting, can reduce basal concentration of metabolic biomarkers associated with chronic disease such as insulin and glucose. We know this thing very well, that overnight fasting can change your metabolic aspects. And also in the animal studies have been shown and supports this hypothesis of intermittent fasting and restricting the availability to chow the normal nighttime feeding cycle. I'll go into little details later. So this is all related to a circadian rhythm. I'll go into again little details about how it affects the metabolic. This is typical of a study which is already published in 2017. And what this elegant study has shown to us, that this is the typical 3 meals and a late evening snack, which we also do in our day-to-day regime. That, and what happens in this particular, which is a routine things, 3 times meals, and then glucose, every time you take the meal, the glucose rises and then again comes to normal. Every time you take the meals, the glucose rises. But if you see the ketones, they are almost in a low level and they are normal. So there is no effect on the ketones levels. If you see in the alternate day fasting, which is a 5:2, which we have shown on the last slide, that glucose pattern, only when you are taking meals, then the glucose rises. But ketones, if you see here, the ketones actually comes down when you take the meals, take the meals on that particular day, and then it remains on the lower level. So this is the ketones level. And in the third one, where the time restricted feeding, 18 hours of fasting every day, you find during the 4 hours meals, the glucose rises. But here, if you see the ketones, they are surprisingly, they are low. During the meals, the ketones levels comes down, and this is obvious because ketones are not needed during the feeding or the glucose rises. So what happens in our milieu, internal milieu, that association of intermittent fasting is usually associated with 2 types of metabolic aberrations. One aberration is in the intestinal microbiota, where the diversity and activity, and another is lifestyle disturbance, that your diet is changed, your sleep pattern is changed, and your activity is changed. And because of this lifestyle aberration and the intestinal microbiota diversity and activity, your circadian rhythm in the brain affects. And because of this central and peripheral circadian rhythm disturbance, you have a metabolic disturbance in the form of whether you have an inflammation and whether you have sex hormones. So it affects both insulin and lipids. And ultimately, because of this cycle, you have obesity. Because of the eating pattern is changed, you have the type 2 diabetes, cancers, cardiovascular risk, so many things. They are all affected through the, so this is the hypothesis of the intermittent fasting. And what happens if you see here, the human circadian rhythm here, this is wake and feeding cycle, whereby your liver, you have an increased glycogen, increased cholesterol, bile synthesis. In pancreas, you have an increased insulin secretion because you are fasting. The fat lipogenesis occurs, adiponectin production occurs. In muscles, you have a fatty acid synthesis. On other side, this is in the sleep or fasting period. What happens? In the liver, it is definitely, in liver, it is the gluconeogenesis, glycogenolysis, and mitochondrial biogenesis. In pancreas, you have increased glucagon secretion, fats, lipid catabolism, leptin secretion is increased, and in muscles, there is the oxidative metabolism. Because of this wake feeding cycle and the sleep or fasting cycle, you have multiple changes in your body. It starts from the deepest sleep here. If you see here, here we know that highest probability of death in this period. This is the early period in the day. It is 4 to 6 in the morning. Then your blood pressure rises, melatonin secretion stops here in the morning. And then you have here highest testosterone secretion in the morning. And then you have highest, you know that you have a risk of myocardial infarction before at this period of time. And this is how your whole day is affected by this type of feeding, fasting, feeding and fasting, and that affects your metabolic health. What happens when you are having the intermittent fasting? And here, if you see here there is an increased parasympathetic tone in the pons here, and because of this you have a synaptic plasticity, enhanced recognition, enhanced neurogenesis, reduce here in the glucose, insulin, leptin, cholesterol, CRP, TNF alpha, all cytokines are reduced here, and there is an increase in the adiponectin levels, and that is very useful for the metabolic health. And decreased resting heart rate, increased heart rate variability here, and decreased blood pressure. So overall effect of the intermittent fasting, if you see the brain, circadian rhythm, that actually affects the positive health. What happens in the other organs, like in liver, there is an increased insulin sensitivity and ketone body production. In the muscles, there is an increased insulin sensitivity and enhanced autophagy, and adipose tissues, there is a fatty acid mobilization and reduced inflammation. So however, the overall effect of intermittent fasting is through the sirtuins. Sirtuins are the basic enzymes which actually on activation, these proteins promote the resistance to oxidative stress. So if you see here the sirtuins here, whether the SIRT1 and SIRT3, this is through the cytoplasmic and nuclear effects, and through the mitochondrial effects. What you see here is the affects the cytokines, inflammatory cytokines in the form of PGC1 alpha, the NF-kappa B, the FOXO3, and this is SIRT here in the HIF1, SOD2 and IDH2. So through this sirtuins 1 and 3, because of the calorie restriction, that antioxidant protective response occurs. So intermittent fasting in general affects the cardiovascular health also, and this, if you see here, through the different mechanisms, they actually affects all. AMPK increased, leptin is reduced, reactive oxygen species reduced, and through this ghrelin, insulin, IGF, and all these things, there is a reduced vascular dysfunction, cardiovascular risk and mortality is reduced, and that's why intermittent fasting is always used. So now let us see how it affects in the diabetes. We know that in type 2 diabetes management, that we want to promote the moderate and sustained weight loss as the primary goal to reduce the cardiometabolic risk, and dietary approaches to reverse the type 2 diabetes. This has been shown at many times and established in the scientific literature that now you can think of reversal of type 2 diabetes by just simple weight loss. And that also will cause the preservation of beta cell mass, and that will achieve the remission of the glucose alteration. And this we have known in the literature earlier. So calorie restriction with its two modalities, either it is a continuous or it is intermittent. And animal studies have suggested that an intermittent energy restriction go beyond weight loss. That is the animal studies have shown, but human studies still have not shown this particular aspect. So let us see the animal studies. There are so many animal studies which have actually shown in the animals that there is an effect in the glucose, the beta cell neogenesis, and that is shown in animal studies. Even beta cell regeneration occurs in the animals, and even some human studies are there, but they are not very, very high number of the human studies are very less, but that has shown positive effect on the diabetes and the different parameters. Human studies are there. I'll show you the little late. So what overall animal and human studies till date have shown? In animal models, we have seen the benefit of beta cell neogenesis for the first time. Percent beta cell mass is increased, insulin secretion is increased, and HDLC also increased. While there is a beta cell apoptosis is reduced, fasting glucose is reduced, and it is the weight neutral. So in the animal models, what human studies have suggested that there is a increased benefits of increasing the HDLC, the insulin sensitivity is increased, quality of life is better, coma IR is also increased. However, the fasting insulin weight and lipid profile is reduced. So that means it is such much a beneficial effect in the human studies have also shown. So ultimately, whether it is a fasting mimicking diet you can take, the less energy, or alternate day fasting or time restricted feeding, all have beneficial effect in the diabetes. So myth is exploded in the first time this paper is published when it is said that this is a Canadian group for the first time in a clinical context, the capacity of intermittent fasting to reverse type 2 diabetes for the first time, and they have given the molecular mechanisms behind this. And this is a 3 patients study they have shown. And what this study, this is a patient characteristics of the study, patient 1, 2, and 3. And these patients are having the diabetes with comorbidities of hypertension, chronic kidney disease, and hypercholesterolemia. And so this is the 3 patients. If you see the patients were on glargine, the insulin, the SGLT2 inhibitors, metformin. So all these patients, but ultimately what these patients have shown here, this is the alternate day study. And clearly all the patients have shown the effect and reversal of diabetes, almost reversal of diabetes. If you see here, whether patient's weight loss is there, whether the initial waist circumference, and the insulin reduction is there. So this is all beneficial in the patient. This is all real patients study have been published. So, but my dear friends, there are risks associated with intermittent fasting. This is not general, this cannot be advised in general to all the patients of diabetes, whether it's a type 1 or type 2 diabetes. Type 1 we don't want. In type 2 diabetes, usually with obesity or overweight patients, I think this is better, but not in the patients who are taking multiple doses of insulin because of risk of hypoglycemia. So whenever you are asking or advising your patient for intermittent fasting, if patient has already a recurrent hypoglycemia, this is not for them. So careful monitoring is required to avoid the hyperglycemia or peaks of hyperglycemia or ketoacidosis. So mind it, if patient is stable usually, and whether hyperglycemia is there and overweight is there, in that case it is there. But if patient is on sulfonylurea, I think sulfonylurea dose should be reduced, or we have to give the short acting secretagogues in that case. This important thing is the loss of free fat mass is also reduced in the intermittent fasting. So we have to take care of certain multivitamins, and because we don't want any vitamin deficiency. So there are other risks also regarding in genetic hypercholesterolemia. Please, this is not the good way of doing the intermittent fasting. But in young women with normal weight, this also is not good, and because they may increase the hunger, they worsen the mood of the patient. So for young ladies, this is not the right thing. So my conclusion from this particular very new concept, take it a pinch of salt, that this is not for every patient of type 2 diabetes. So, but this is a new concept, probably in next future years, 5 or 10 years down the line, you will find this is a new modality of treatment in type 2 diabetes. We have already seen here the molecular mechanism of intermittent fasting or energy restriction in animal models have shown positive results in type 2 diabetes. The reversal can be there, the neogenesis of the beta cells can be there, reduced apoptosis of the beta cells, and ultimately with these animal and the human studies in front of us, this is a new concept. Clinical studies are emerging. Type 2 diabetes, intermittent fasting is not that ultimately with that risk, and it is in certain cases, this is beneficial, and if we can do judiciously intermittent fasting in our type 2 diabetes, overweight or obese patients, I think we can think of reversal of diabetes through this intermittent fasting and weight loss with this regime. So these clinical studies are definitely needed to evaluate the functional capacity and mass of beta cell in the human studies. So still we are in the infancy stage as far as advocating in general the intermittent fasting in type 2 diabetes patient. So my dear friends, I have given the first time this view of new viewpoint of a new modality of management in type 2 diabetes. Intermittent fasting can be one modality in certain cases of type 2 diabetes. Thank you very much. So I can.
Thank you for that wonderful talk. Now, as we are running short of time.
I know, but this is something which can intimidate some new questions because it's a new thing and it is very difficult to digest, as you have earlier said.
Okay, okay.
Dr.
I
Asha.
think we have a previous topic to complete.
Yeah, we will now continue our session with Dr. Devin Prabhakar for a few minutes, and after that we will have a short discussion.
Okay.
So, okay.
Yeah. Thank you. Can I start now?
Yes, sir.
Yes, sir.
Yeah. I'll be fast and I'll finish it off very quickly. Now, when we look at the options in diabetic clinic on how to do screening, what we can do is we can buy a non-mydriatic fundus picture. It takes only 10-15 seconds to capture an image. Then you can send it across to an ophthalmologist you are in tie-up with. Can I have the next slide? And these the cameras can be even based on a mobile phone and works out quite cheap. Previously, the cameras used to cost something like 10 to 15 lakhs. Now you can go from around 2 to 3 lakhs. And now 3.5 to 4.5 lakhs, you get a very good fundus imaging system. Next slide, please. And when we go to the software, it gives all the details. Like I can get the patient's fundus picture. I can get all the history that he gave, the medicines that the patient is on. And I will be able to give a comment on whether this patient needs to be seen by an ophthalmologist or a routine checkup in an online consult would be good enough. In this way, in this COVID time, when a patient is not physically able to move from clinic to see multiple doctors, when you have a standalone diabetic clinic, and if you cannot have an ophthalmologist in-house, you can invest in a fundus camera like this, send an image across to an ophthalmologist, and they can do 100% thorough screening for you and let you know whether the patient needs to come in, needs a laser, things like that. Next slide. Now, next slide, please. Now, when we look at it, what are the risk factors that onset of diabetes, how long the patient had diabetes, whether the patient is on good diabetic control, whether the patient is pregnant, hypertension, nephropathy, hyperlipidemia, obesity, anemia, smoking, and cataract surgery can worsen it. Now, when we look at it, sometimes we need a further image into there that is called the OCT imaging. Now, when you look at this slide, you can see that the first part shows the histopathological section. And on the right side, you have a graphical representation of the retina. And if you look at the OCT image, it almost gives a similar picture. The OCT looks like a histopathological section, and the ophthalmologist is able to pinpoint in which part of the retina the problem is. That is the level of detail that an ophthalmologist is able to go through in analysis of diabetic retinopathy. Now, next slide, please. The next slide shows the follow-up required for a diabetic retinopathy patient. Always, we need to do an annual refer to see the fundus once a year to make sure that the patient's vision can be maintained throughout his life. Now, if it's a mild NPDR, we say once in 9 months. If it's moderate NPDR, 6 months. If there is any diabetic macular edema, that yellow spots in the retina, then we need to see the patient once in 6 months. And if he's having significant macular edema, once in 2 months, and if it's a proliferative diabetic retinopathy, at least monthly or 2 monthly. Next slide, please. patient asks the doctor, the physician, or the ophthalmologist. Now, the main question in the patient mind is whether he will have vision throughout his life, whether he will go blind. Because the treatment of diabetic retinopathy is quite expensive. One doubt he has is whether he'll be able to afford the treatment. So these are the questions that we have to ask and we have to answer together with the physician. Now, to answer these questions, if that sugar is very well controlled, we should be able to preserve the patient's vision throughout his life. If he has already lost his vision, then with intravitreal injections, with maybe cataract surgery, his vision might improve over time. The main thing is we should never let the patient lose hope, because sometimes only thing he has is hope, and the ophthalmologist and the physician have to work hand in hand. Like Dr. Jothydev always says, diabetic treatment is a teamwork. We have got ophthalmologists and we have the dietitians also. So with these things, we can reassure the patient. Next slide. Now, when we talk about the future, we will be talking about the way forward. It will be like it's a video. So the things are going online. Even this conference is going online with so many participants. Just like that, even the ophthalmologist clinics is going online. When I see a patient, I now use a digital camera on my slit lamp to take a photo of the eye. Even the patient might not be able to come in, because if he goes into, if he's from a containment zone, or if I go into quarantine, then I'll be using these images to follow up the patient. And these images can be acquired by my optometrist even without me being in the clinic. And this is the way forward. And next slide, please. And this is the way when we talk about diabetic retinopathy screening, things are going to change very much in the new normal. So I may not physically be seeing a patient. The patient might be in Dr. Jothydev Diabetic Center. He might be in Bombay. He might be in Delhi. And I'll be just seeing the images on my mobile, and I'll be computing and treating it maybe in the mobile itself. So we got a lot of these applications that have come in, QKDoc, CallDoc, Vidal Health, and my hospital, we have started our own portal. So all of us doctors, diabetologists, ophthalmologists, nephrologists, all of us have to look at the future in a digital age when we'll be doing screening, maybe even treatment online. Next slide. And that is that overview I've given about the future, how diabetologists should be using technology to do the screening, whether it be in his own clinic with an ophthalmologist, or if you are capturing an image, even from your mobile phone, it is possible to capture the retinal images now. You can share it with an ophthalmologist who can give an opinion and then say that whether the patient needs to be on regular follow-up or not. And with that, I think I've been able to complete this presentation without too many hitches. Thank you very much for the patient listening.
Thank you, sir, for the wonderful presentation. So we can move on to the discussion.
Yes, sir. Yes. Session is open for the discussion. Since we are out of time, I request the distinguished to have a very short discussion.
I've seen one question here
Any
in the
questions?
chat box.
Any questions?
Shall I answer that particular question? This is regarding the 14 hours fasting in one patient. Hello, am I audible?
Sir, yes, sir. You may.
Yes, sir. Yes, sir.
Yeah.
Yes.
So this is regarding 14 hours fasting in a patient. Here, there's one of the colleague has asked. I think there are two points here, and two things have to be remembered whenever we are asking for the intermittent fasting or this type of 14 to 16 hours fasting. Then monitoring of blood sugar is very, very important. You have to monitor either self-monitoring of blood sugar is important 4 or 5 times in a day, or if you have a facility for continuous glucose monitoring, then I think this is much better to have a continuous glucose monitoring during this period. This type of 14 to 16 hour fasting is not for a longer period of time. We can have 2 to 3 weeks or 1 month at a stretch, and then we have to discontinue this thing. So this cannot be continued for a longer period of time. If you achieve the weight loss within 1 month or so, or 4 weeks to 6 weeks time, it is okay. Stop intermittent fasting, and then you can do your regular diet restriction later on to maintain this weight loss. So this is how we do the intermittent fasting in our patients.
I have a question to Dr. Tejas Shah.
Sure.
Actually, we were in public health sector. We were using glibenclamide as a anti-diabetic medicine previously, but there is a shift to the glimepiride in most of the public health sector. Is there any study revealing that after shifting from the glibenclamide to the glimepiride, is there any change in cardiac mortality in a large scale to our population?
No, as I showed you, there is no head-to-head comparison study. Whatever the studies, what I showed you also in the presentation, where they have compared glibenclamide to and comparing the cardiovascular mortality of glibenclamide to glycoside and glimepiride, and they found out that the hazard ratio was much lesser with glycoside and glimepiride both, 0.6 and 0.9 as compared to glibenclamide. So definitely most of the studies till now have shown that the older drugs had whatever higher risk, but the newer drugs are cardiovascular safe. But there is no head-to-head study between glibenclamide and glimepiride as such for cardiovascular safety.
Okay, thank you. I think there is no other questions.
No other questions? Yeah.
Okay, thank you.
Thank you. Thank you so much.
Thank you, Dr. Tejas Shah, Dr. Devin Prabhakar, and
Thank you,
Dr.
Dr.
Arvind Gupta for the informative
you very
and
much
this
for the
short
opportunity.
session.
Thank you very much.
Thank you.
Thank you.
Also thanking Dr. Benny PV and Dr. Sandeep R and also Dr. Asha Ashik for being an enthusiastic chair. By this, we come to the end of today's technical session in Winter Hall. We will start the session tomorrow at 11 a.m. Thank you all for participating in this and being patient. Thank you and good night.
Good night.
Good night.